And Martha always says, and how it's a difficult journey that they have. And our next speaker is a successful migrant who was born in Dublin, but his family wanted to get as far away as possible from the English, and they went to Australia, where, of course, he's been a great success and have become other things. The Australian of the Year, is that what it was called? Yes, says he modestly. Yes, so what a great thing. Anybody here is the Dutch Psychiatrist of the Year, or not a Dutch Person of the Year, or Eric, the Hong Kong Person of the Year. Anybody else? The Person of the Year of their country, not just for psychiatrists. I'm sorry, I'm doing my best to embarrass you. Anyway, Pat has really made his name on early intervention, that the idea that it is much more beneficial for young people to be treated by a team that's dedicated to them, and started in, I guess, the 1990s in Australia, and then spread around the world. So largely due to Pat, not just the idea, but also founded a conference, a very expensive conference, I'm afraid, and a good conference, but I guess probably you don't get much money from drug companies because you're too holistic. Thank you. And then also a journal as well, and subsequently then moved on to earlier intervention, and then to the question as to whether it was better, rather than try and just see people en route to psychosis, to have clinics for youth mental health, which of course has become subsequently a very big thing. So without further ado, Professor McGorry.
Thank you. Well, good morning, everyone, and thank you, Robin. Firstly, I'd just like to thank you and Marta for inviting me to this amazing meeting. It's just a really wonderful atmosphere and culture that you've developed, and privileged to be here. Thank you. And to acknowledge Robin too, because when I was a young psychiatrist, Robin was one of the leaders in the schizophrenia field. I was a schizophrenia person, and this community, Eric and I were saying the last couple of days, we've been lucky to have these great communities around schizophrenia and psychosis over 40 years, really, and everyone helps each other, and we learn from each other, and it's really wonderful. So I was chatting with Robin a minute ago, and what really gave me the idea for early intervention was I was a medical registrar for a number of years, and I worked in diabetes, and we had a unit in Newcastle in New South Wales where newly diagnosed diabetics were referred, and they had to adjust very rapidly to the onset of a very life-changing diagnosis and learn a lot about self-management of the illness. And even for them, it was incredibly hard, especially if they were young adolescents or young people. And so when I got into psychiatry, I could see that the challenge for people newly diagnosed with a psychotic illness was going to be about 100 times more serious. So I'll come back to that anyway, but that was really the idea. Okay, so I'm going to try and, I don't know if I can fit it all in, but I'm going to try and take you on the bit of the journey of how this field has developed. It's really a field building exercise, and it's certainly an international collaboration really that's done it, actually. We've all played our roles, but you'll see. So anyway, for the Australians in the audience, they probably all hung over after going out last night, but if there's any of them here, this is our map. This is our, I don't know, does anyone know where that sculpture is on the left? Does anyone know where that's located? It's the world. It's the world, but where is it? What city is it in? It's not in Australia. It's the Australian view of the world, but it's not in Australia. It's actually outside the LSE in London, the London School of Economics. So, and that's on the right is our mothership in Melbourne, Origin. So, but this is where we first started working with first episode patients in 1984 in Royal Park Hospital in Melbourne, where John Cade had been the superintendent of the hospital. He had died a few years earlier, but this was our very basic, in a mental hospital, first episode unit. We set it up for first episode psychosis in 1984, and immediately you could see we set it up to study the onset, study the illness in a purer way from a research point of view, but actually immediately you could see they were completely different from all the other patients in the hospital. They were all young, they weren't 45, they were terrified, they were over-medicated, as Robin said the other day, given about 10 times as much medication as they really needed to get better, and their families were distraught. They'd usually come into hospital in a life-threatening crisis with the police or a suicide attempt, and they'd been ill for a number of years in many cases before they got any treatment. So you could see it was obvious what needed to actually happen. You didn't need to be have any high IQ or anything. It was absolutely straightforward, and that's where we started anyway. And then other people around the world obviously were concerned about the same issue, and we gradually linked up through these networks that Robin referred to, the International Early Psychosis Association, which is now more general in early intervention. Next one of those is the 17th one, I think, now. It's going to be in Auckland, New Zealand, next year. And the other thing, as we transformed our early intervention focus into a transdiagnostic youth mental health paradigm, we set up another network which is really powered by young people as well as researchers and clinicians, and it's had about 7 meetings over the last 15 years or so, and the next one is in Dublin in November, actually. And young people co-convene it, they co-chair every session, and about a third of the audience is young people. And about 20 years ago we set up a journal to try to make things more scientific. These are vehicles to actually develop a field, and at that time most of the research was in psychosis, not in other syndromes or other parts of the diagnostic spectrum. So it was to encourage early intervention in depression and anorexia and all these other sort of major conditions, and it sort of worked. I mean, there's a lot more of that happening in those other parts of psychiatry, but still not enough, probably you could say. And Ashok Malla wrote this paper about this transition or this evolution from early intervention psychosis to youth mental health. And then obviously there are other things that you can do to develop a field, and writing textbooks is one thing. So now I want to go back to something Robin touched on in his talk the other day, the issue of diagnosis and how to think about these syndromes. It's obviously still very controversial. You see these, culture wars happening on X and Twitter around this stuff all the time still, very ideological. But I want to quote an Italian philosopher, Antonio Gramsci. Does everyone know about him?
Gramsci. My mum is a professor of philosophy, so I grew up surrounded by books by him.
Oh, great, yeah. Well, obviously a great man, Marxist philosopher, one time leader of the Italian Communist Party. And he has this great quote, which I kind of use for why we can't come up with a better diagnostic system. We know the current one is not very good, but what do we put in its place? Given that we haven't got the biomarkers and all those sort of things sorted really. So it's like a debate happening around this. Dan Stein, the late Dan Stein, wrote a very nice paper arguing for incrementalism on diagnosis. In other words, don't have a paradigm shift if you don't have a paradigm to shift to. This is his sort of argument. But we actually organised a workshop in Amsterdam just on the eve of the pandemic in 2020 with all of the people that had tried to come up with new diagnostic approaches, like high-top. The high-top people were there, the RDoc people were there. Niall Boyce, the editor of Lancet Psychiatry at the time, facilitated it. The editor of JAMA Psychiatry was there. Caspi, Echelon Caspi was there, the P-factor person. So all of these ideas were kind of tossed around for a couple of days, and we produced this paper trying to integrate these things, probably only with partial success, I'd say. Clinical staging is the one that I'm going to talk about in a minute, which is our take on it. But basically, we thought that we had to understand these early clinical phenotypes and really to try to make diagnosis to have better utility. And the syndromes, the DSM categories are not that useful for treatment selection, really, because many of the treatments are transdiagnostic. But if you look at the stage of illness, if you try to classify people according to what stage of illness they're at, you might have a better guide to treatment selection. And certainly you can study the treatments and try to prevent progression from one stage to the next. And also the biomarkers might make more sense. So. And the question is, do these early clinical phenotypes, are they pluripotential or are they sort of pre-programmed in some way? And that's really a testable hypothesis. So we started with about, must have been over 30 years ago now, operationally defining this pre-psychotic phase. We knew from Hefner's work that it's quite a lengthy prodromal. If you look backwards, you can see that the people had been developing problems and symptoms before they became psychotic. The positive symptoms emerging was a late development in the first psychotic episode. So could you do that prospectively? Could you define that at-risk mental state or that ultra-high risk state prospectively? And was defined, and it really had a big effect on I think, on schizophrenia and psychosis research, because there was a very increased risk, but the field has evolved quite a lot. And at the moment, there's a very big study which we're involved in called AMP Schizophrenia, trying to sort of, I suppose, look at more mechanisms and biomarkers in this group. There's a sample of about 2,000 patients collected from all around the world. And I don't know if it's going to work, actually, because it's, in one way, it's just another version of Naples, the US study, but whether it's any advance or not, I'm not really sure, but certainly a lot of money has been spent on this one. And that's the group that's doing it. So, but when you define this at-risk mental state or this ultra-high risk for psychosis state, you get several different outcomes. The early studies showed a transition rate of 30 or 40%, but now the transition rate's reduced, but the patients don't necessarily get better. They often grumble along with subthreshold positive symptoms, or they develop other syndromes. And so this is one of the papers that when you follow these patients up, only about 9%, I think, don't have a psychiatric diagnosis. So they have something wrong with them, but it's not necessarily progression to psychosis. They either already have or they develop mood disorders or combinations of substance use and mood and so on. So it's really a transdiagnostic group with multiple different outcomes, of which psychosis is one of the perhaps higher valence outcomes. And Robin and his colleagues wrote a critique of this approach, really in the way it was structured as specialised clinics. And I actually agreed with this because the minority of patients that end up with a first psychotic episode come through this channel. It's too narrow a channel in a way, and we're not accessing those patients well enough. So that's a bit of a segue into what I'm going to talk about next. And Jim Van Os too, looking at it from a public health, population health point of view, showed that that you're basically getting to different levels of enrichment for risk. And in recent years, we've probably been sampling down the more shallow end of the pool for these studies rather than closer to the actual onset. So the transition rates are quite low in many of the studies that we're looking at. So that's and I don't think the Americans really have understood population mental health at all. They just think if you've got a phenotype, you've got the phenotype. And so I think Jim was spot on there too. So we started with Barnaby and other colleagues, Barnaby Nelson, we started to try to to see that at-risk mental state as a sort of a or less specific early stage, and it led to this thinking about the clinical staging model. So if we look at the onset of mental disorders, I think everyone knows now that it's the mirror image of physical illness, really. Physical illness happens in younger children or in people in the over 50s, really, particularly more chronic medical illnesses. And mental illness is the opposite. You know, the adult-type disorders start to emerge in around puberty, and then show you that. So this is the disability-adjusted life years, and the impact of mental illness is really in this teenage and young adult age group in terms of disability-adjusted life years. Half of the burden of disease in young people is due to mental illness. It's their main health problem. This is John McGrath's work from using the Danish, and I think lots of other data, actually, not just Danish registers, but showing that the modal age of onset is 15 for mental disorders, and then there are other peaks as well. Some of the syndromes have different, but the general pattern is this is a very high risk period for the onset of mental disorders. And how do they onset? This is Jim Van Os's paper based on Dutch network analysis, thinking. How do you become mentally ill? How do you go from being not mentally ill to mentally ill? It doesn't happen like turning on a switch. You evolve, you merge into it. And this idea is based on symptoms being risk factors for other symptoms. And then they might cohere or they might ebb and flow, but eventually you get a syndrome or you don't. And so you can imagine if you're a bit jet lagged and you're not sleeping well and you start to worry about things back home, and then the one thing can lead to another. This is the way it sort of works. Now, I'm going to ask, is it Marco? Marco, could you just, yeah. So this is using EMA, experience sampling, to show how symptoms can evolve over a period of time and the relationships between different symptom clusters change. And that's how a syndrome would be formed or not formed. And we haven't done enough of that research around the onset of disorder to really learn how they actually form and how stable they are and what happens, the progression. Certainly when you're working with young people in headspace centres, you see these young people come in with fragments of different symptoms, and they're certainly impaired, but it's not quite clear which direction they're going to go in, and this is the way to study it, I guess. Now, the Dunedin study that Caspi has obviously been heavily involved in, he published this paper, I think it's 2021, showing a lot of very interesting things. It's a sample of 1,000 patients, 1,000 people that were followed from late primary school, I think, up to the age of 45 and beyond, and a famous study. And you can see that the age of first mental disorder diagnosis is in this teenage and early adult period again. And the interesting thing is that these are called Sankey plots. I don't quite know what that means, to be honest, but it looks very pretty. And what it shows is that by age 45, it's incredible that only 15% or 16% of people did not have a syndrome, did not have a diagnosis of poor mental health at some point. It doesn't mean they all needed to see psychiatrists, but it's normal to have periods of poor mental health in your life, just like it is normal to have periods of poor physical health from time to time. So it doesn't mean they're going to get a chronic disorder, but at any one time it was about 40% of people met criteria for a diagnosis. And the earlier this emerged, the more likely you were to have multiple diagnoses, so even up to 5, I think, in the youngest group. And he actually is the person that's promoted the P factor, the common sort of underpinnings of all mental disorders, and you can see the comorbidity that ebbs and flows in this really supports that idea too. So it's kind of challenging to work out how to make sense and how to work with this. And then the Dutch people that we've been working with have looked at complex systems theory, and these are papers that were published a few years ago looking at how not just first onsets but relapses might actually occur, and how systems might be more stable and resistant to onset, and then maybe with stress and other variables, you become less resilient. And they look at this term resilience. It's very interesting, and I think unfortunately my IQ isn't good enough to understand a lot of this stuff, but it's very interesting. Especially this guy, he's a climate scientist, Martin Scheffer, and he sort of applies some of the thinking from complex systems like climate and even the financial markets to actually look at the onset of psychiatric symptoms. So it's a much more sophisticated way of looking at how symptoms actually evolve and emerge. So if they're this fluid, why classify at all? Why not just say it's just a mess? And so I mentioned that workshop. We try to grapple with that. But there is a way of imposing some sort of categorical value on it, other than syndromes, other than sort of operational syndromes. Syndromes are probably important still, but the stage of illness, and obviously, and this is an idea that's very strong in the rest of medicine, especially in oncology, but also other areas of potentially chronic diseases. It probably applies for any group of illnesses that have got a tendency to become chronic. Yeah. And we started writing about this about 20 years ago. It was like a framework for our research, a heuristic sort of framework for clinical trials and looking at biomarkers as well, because I'll show you in a minute. And a lot of papers have been written about it. It's probably still stuck in the heuristic stage, I'd say. It's still not able to be used properly in everyday practice, I wouldn't say. And so we started off with a simple idea of staging related to psychosis, but kind of realised that, as I showed you before, that even when you're trying to focus on psychosis, you end up with other outcomes as well. And so maybe try to make a virtue out of that and try to define what the early stages of a common trunk, if you like, and there are multiple pathways to different, more clearer, stable syndromes. But even that may not be right, because a lot of these things down the bottom are still comorbid with each other in more established illness. So it's a bit too simplistic, even this. But so it's really trying to find treatment-relevant subtypes by syndrome and also by stage, because the principle of staging is that if you're treating earlier, the treatment has to be safer, so the risk-benefit has to be there, and that's been a big debate with ultra-high risk. Treatment has to be safer, but it also has to be more effective. If you're treating earlier, you have to show a better outcome, and that's very clear in cancer. If you find stage 1 cancer, the outcome is better, and you don't have to treat with with treatments that cause so many adverse effects. So that's the idea of staging. And if we can show that's the case in psychiatry, then and I think we can, then it's a very useful way of approaching. And it also deals with the anti-psychiatry people, because they criticise us for causing harm. But the key guide here is the risk-benefit analysis at each stage. And so we tried to write as much as we could with the literature that's available on this. A few years ago, there's a book about it. And you can also link the biomarkers by stage as well. And if the biomarkers, if they're true biomarkers, they might actually redefine what the diagnostic framework would look like. And staging might help you to do that, because clearly the biomarkers are not going to be exactly the same as the DSM categories. They're going to be, like inflammation will be a transdiagnostic biomarker, almost certainly, for example. So that was a paper that was written in 2015, trying to look at the data on biomarkers by stage. Unfortunately, there wasn't much literature outside of psychosis. It hasn't been looked at by stage in many of the other syndromes yet, but maybe there's more data on that now. Okay, and Christian Keeling in Brazil has applied this idea to public health from a more public health point of view. So it's getting a bit of traction as an idea, at least. Okay, so why have we talked about that so much? Well, I think these are the kind of conceptual tools that we need if we're going to expand the early intervention focus into youth mental health more broadly. And this is a movable feast. Youth mental health, it's changing. The Surgeon General, the previous Surgeon General, basically described it, I think it was in 2021, as a youth mental health crisis. And, surprised people a bit by saying that young people these days Their challenges are unprecedented and uniquely hard to navigate, and the effect that they're having on their mental health is devastating. So he was incredibly strong statements. Fairly conservative-looking guy. I think he's in a naval uniform there, so not prone to hyperbole, but that's what he said, and he is an advisory to the President. And we looked at it in Australia. It's an editorial from the Medical Journal of Australia, written. They made me write it with I'm a youth psychiatrist, but they made me write it with a child psychiatrist, a proper child psychiatrist, and a proper adult psychiatrist. So Michael Burke and Dave Coghill were the co-authors on this. So we looked at it and wrote and published that. But is it real? Is it really? Is there a real crisis? Is it a mirage, or is it this tsunami of increasing mental ill health in young people? The public thinks so. I mean, we did this survey with it's like a public polling survey with the Policy Institute at King's, Bobby Duffy and his colleagues there. We did it in Australia and the UK, and the general sense was, I mean, older people were quite prejudiced about young people. They referred to them as snowflakes and stuff like that. But they did realise that things were bad, getting worse for young people, whatever the reason. But some people are quite rightly saying, is it real? And there are, this Lucy Fuchs from Oxford, it's quite a clear and quite a good book. And we've had massive amounts of mental health awareness and public education and destigmatisation. And so what have been the effects of that? We've assumed that would be completely harmless and positive. But actually, maybe, we've had some benefits like improved recognition, especially in common mental disorders like anxiety and depression. But there is concept creep. If you look at the spectrum conditions like autism, which has been converted to a spectrum, and ADHD, which subtly has been converted to a spectrum as well. And then you have this phenomenon of self-diagnosis and false positives, which is characterised in this book by Suzanne O'Sullivan, who's an Irish neurologist working at Queen Square. A really great book, but quite controversial because a lot of people didn't like what was in it. It wasn't just about psychiatry. It included a lot of vague neurological conditions and other. Wherever there's vagueness and people are suffering, they identify with a certain label, and it's hard to prove or disprove that they actually got the thing or not. And she talks about that very well, and with a fair bit of understanding of the people. It's not blaming them for actually self-diagnosing, but it's not actually the right thing, and there's a problem with the concept. So this is probably, I think this is actually happening around the edges, but there is a real increase despite all of that. So TikTok's obviously not helping. But so we published this in 2024 as 5 years of work from 54 authors around the world, including 10 young people who were co-editors and co-authors, young people with lived experience from different parts of the world, and it was a Lancet Psychiatry Commission. And when we started it, we didn't realise that it was getting worse. The situation was, there was another sort of thing to sort of try to build the field, to actually focus on the facts and also to define what was being done about it in terms of reform around the world. But what it showed was a pattern across a number of high-income countries where over the last 15 to 20 years, and some of this data is very good methodology, showing there's been a genuine increase in diagnostic level mental disorders, mostly common mental disorders. I don't think many of these studies look properly at, say, psychosis or bipolar or anorexia. They're too low prevalence for the methodologies to really capture, but so we don't really know, although we've seen some data here suggesting there's an increasing incidence of some other more low prevalence conditions, but certainly these anxiety, depression, those sorts of things are getting worse wherever they've been measured. And Australia, I'll show you the Australian data in a minute, but Denmark, and Merete Nordentoft shared this data with me. The pattern in Denmark is the same as Australia, especially in the young people over the last 10 or 20 years. I think it's 10 years here, and worse in young women than young men. And in Australia, we found the same. This is the latest National Mental Health Survey, completed a few years ago now, and 15 years after the previous one. And the average level in that 16 to 24 age group is 39% of young people met diagnostic threshold, which is 2 out of 5 young people. And you can see that the rates are lower in older age groups. And if you look at the change from 2007 to 2021, about a 15-year period, you can see there's been a 50% increase in prevalence over that period. And this is community sampling. It's not based on help seeking or it's actually the actual snapshot of the prevalence in the community. So it's real. And the females are worse than the males again. Why? I could go into more data, but the big question is, why is that happening? So in the Commission, we tried to look at some of the possible explanations, and we can't prove anything because it's all associations. You can't do an RCT, randomising people to, more social democratic policies versus, hardcore right-wing policies in society or social media exposure or not. You can't do these. You can't do RCTs on this, so a lot of it is opinion and association. So one thing is clear: if you talk to young people and their parents, people are more pessimistic about the future, and for obvious reasons. And does everyone know who this fellow was? American baseball player who came up with these very paradoxical statements like this one. So we didn't look at all of the things we should have looked at, but these are some of the things we did look at. COVID-19 as a cohort effect. It probably explained about 25% of this increase over the 15-year period, and maybe some of that is just a cohort effect and maybe it'll settle down a bit. There may be some data on that since then. Socio-economic conditions and inequality, climate change, social media, smartphones, insecure employment, and just the intergenerational inequality. These are some of the things we tried to look at. The Surgeon General in his advisory just documented all the things that we know are risk factors and protective factors for mental illness. Most of those have got a lot of evidence behind them. Now, either these things have got worse, like the known risk factors have got worse, and maybe some of the protective factors have weakened, or there are new things happening in society causing this worsening of young people's mental health. And the Australian social scientist a few years ago, Richard Eckersley, said young people are the miners' canaries of society, meaning that they are the early warning system for something going wrong with the society. Because they're in a much more vulnerable stage of life, they're transitioning from their families to a peer group to becoming independent of their families. So the peer group's kind of fragile and fickle. They're in their vocational part of their lives, education, and that's also like a vulnerable sort of period, especially with what's happened to higher education in recent years. And anyway, there's lots of reasons why all those developmental tasks they have to face. It's a very stressful period of life, even if you're successful in navigating it. It's a very sort of high stakes period of life. So this is some of the COVID data. You can see that there was a much more profound effect on younger generations of COVID for the reasons I just said. Probably they're much more vulnerable to what actually happened in COVID, and while older people were more vulnerable to actually the effects of COVID itself, all the things that happened around COVID, including government policies, actually harmed young people, and I think the evidence is pretty clear for that. Social media now in Australia, our government has drunk the Kool-Aid on this one and sort of banned social media for under 16s. And obviously there are a lot of harmful effects of social media, like the Surgeon General pointed out, but there are also a number of positive effects of connection, especially during the pandemic. It was very helpful to subgroups of young people. So it's like life. There's positives and negatives to it, but the problem is it's so unregulated, and there are a lot of very harmful aspects which have been characterised. And this fellow, has anyone read this book, The Anxious Generation? It'd be interesting to see what you think of it, but he's very persuasive. He's an incredibly good writer, and he wrote another interesting book called The Coddling of the American Mind about overprotection of children a number of years ago. But he's really a salesman. I mean, he's oversold it big time, I think. I don't know if you agree, Iris. He's nodding here. I mean, there is an argument there. And a lot of the things he actually recommends are not that controversial in the book, but he's trying to explain the whole of this worsening of the mental health on the basis of this one factor, and it's probably not true, you know. And is there another way to deal with it other than a complete ban? You know, and that's being debated, I think, in the UK at the moment. I think Starmer, British Prime Minister, is just considering whether to ban social media as well. So it's an example of, for every complex problem, there's a solution which is clear, simple and wrong. But parents love it. Parents love this idea. So this is why our Prime Minister did it, because he knew that the middle-aged parents would love this as a populist sort of decision. But one of the cartoonists in Australia, Kathy Wilcox, made this really great point that, you know, swimming pools are dangerous, and you know, surfing beaches are dangerous. We don't stop young people from going to the beach, you know, or to the pool. We teach them how to swim, and we put lifeguards on duty, and we regulate it. We make sure that it's safe, you know. And maybe that's not possible with social media. I don't know whether you can make Elon Musk do anything, or Mark Zuckerberg, but I don't know. But so it'd be interesting to see what you all think. Climate change, we looked at this in a report. We have a policy centre at Origin, which is the thing that collaborated with King's, and so we produced a report on climate change, and that clearly is a big issue for young people. Probably the vast majority of them are pretty worried about that. And again, it's like there's an economic driver. The reason nothing's happening about climate change is purely economic. So economic factors, we looked at this as carefully as we could, and probably revealing my political biases here, but this is a great book written by a Guardian journalist called George Monbiot and a filmmaker called Peter Hutchison about neoliberalism, about what happened in the 1970s and 80s when people switched around the world from Keynesian economics, which is a post-war collectivist sort of approach to society and led to the welfare state and, you know, much more, you know, looking after each other type thinking, to this really ruthless market theory of Milton Friedman, which treated everything as a commodity, and the private sector was superior to the public sector in everything. So everything, there was public assets were sold off, health and education were turned into commodities in a much more serious way, and they document what the results of that. And it was really because of Margaret Thatcher and Ronald Reagan having the same sort of approach at the same time, and then communism sort of folding. And so this just became the only way to do things, and that's why it's called the invisible doctrine. And they sort of chronicle all the harms that has caused. Now, you may not agree with that, but that's one argument that we looked at. And this is a book called Gen F, which probably sums it up about the current generation, by an Australian social scientist called Alison Pennington. And she takes up a number of these sort of themes, including the casualisation of work and the housing crisis for young people, intergenerational inequality and so on, and sums it up with there's like a loss of security, and young people's lives are much more precarious than they used to be. Now, not all young people. People with affluent parents have got a safety net and a protective, but the bulk of young people are in a more precarious position than they were. One example being housing costs. 40 years ago in Australia, it cost 3 times the median income to buy a house. Now it's 10 times. And the rents are accordingly up too. So you've got students in Western Sydney that have to choose between food and textbooks. I don't know if it's the same in the UK and elsewhere. So inequality, this is great work by British epidemiologists, and they've shown how inequality has worsened across the world, and also documented what is the consequence of having much more unequal societies. It's not just mental ill health, it's things like teenage pregnancy, incarceration rates, homelessness rates. Every social evil you can think of is worse if the society is more unequal. It's not even about the average level of wealth, it's about the level of inequality that's the more powerful predictor. And this has enraged people like Vikram Patel, who wrote this very passionate polemic in Lancet a few years ago, talking about the structural violence of public policies that are harming people, and there's no accountability for politicians bringing in policies that actually are harmful to the people in terms of their mental health. It's written from a human rights perspective, actually, but it's the same sort of thinking that I'm sort of sharing here. Okay, so the summary is really things are getting more problematic. It's probably due to the changes in society rather than anything sort of genetic or biological that's changed, although there could be biological threats that are happening that we haven't considered. But anyway, it's complicated, and because of the rapid rise, prevention, I think Robin was talking about this on Monday too, that prevention is really got to put a lot more effort into prevention as well as dealing with this increase, this cohort of people we've got to treat. We've got to try to work out how to turn off the tap. And it might be hard because of some of these things I've mentioned they're not easy to reverse. How do you change the economic theory that's inspiring governments? How do you stop climate change? I mean, some of these things are difficult. So the public probably recognising that, they actually think, well, let's do something now. Let's do something to help these young people. That's what this survey said. We've got to actually provide effective help for these young people who are struggling or developing more serious mental illnesses. So that's where this field-building idea, coming back to what I started talking about, I started off with psychosis, intervening early and trying to have much better disease-modifying outcomes for psychosis. Well, it's a more general thing. We've got to build a stronger field. We didn't actually think early psychosis was going to be a strong enough sort of idea or concept to change everything in psychiatry. It changed a bit, but it's patchy still. But youth mental health could be, when you look at the public health burden and also the effects on the cohesion and prosperity of a society by sacrificing a whole generation of young people, that's a very powerful idea which almost anyone can understand, this idea of mental wealth. That if you neglect a major public health issue that strikes at that time of life, on the threshold of productive life, if you don't deal with it, then... So this is a bigger idea. Now, whether it's going to work or not, I have no idea, but, So what are the principles? It's not just about getting early in the course of illness. It's about this phase of life, the developmental challenges of moving from childhood to mature adulthood. And it doesn't finish at 18. Maybe, in the 1930s it finished at 18 or even earlier. In Charles Dickens it was probably like 8 or 10. But now it's people are not in secure adult mode until the even late 20s in some cases. And that transition starts even a bit earlier. And we've had the weakest part of our health system around this age group. If you look at the way mental health care is funded and structured, where all the resources are, they're in little kids or they're in middle-aged people. There's a big hole, or there has been until recent times. And young people, if you talk to them, in this age group, and they try to access the services that were existing, say, 20 years ago, and mostly still exist, it doesn't feel right. They don't feel that it's not really for them. They don't engage. And so, over the last 20 years, there's been an international effort, particularly around the primary care, enhanced primary care level of services, to build a new system covering this puberty to mid-20s sort of idea. And we've written it up in different places, including most recently in this Lancet Commission. And I won't go through all this, but it's possible to define what are the key elements of this culture of care, this approach, which differ from child psychiatry, child and adolescent, and differ from older adult psychiatry. But that's all in the commission. And, there's a certain amount you can do in high resource settings, and you can probably have to do different things in low resource settings. And we use that term, not low income countries, because countries, let's say like India, they're not a low or middle income country. They're a blend of about 3 different types of resource settings. There's very affluent people in India, and there's a middle class, and then there's very poor people. But in the low resource settings, there are very few clinicians, the few resources, so you have to do what you can actually do. It requires a different approach. So that was also addressed in this commission. These are the countries that have probably built I would say, like a base camp in this area of enhanced primary care, particularly Canada, Ireland, Australia, the Netherlands with the At Ease program, and Denmark actually has got headspaces across most of the country, but it's a bit volunteer-based. It's not quite clinical, but nevertheless, these are countries that have been the pioneers or innovators so far, and that's all described in the Commission. Although I've got pictures of all of them, but I haven't got time to show you all of them. But there's a common sort of features. There are common features of them. But in Australia, we started probably 20 years ago with a thing called Headspace. We started off with 10 centres. It was a $50 million grant for the whole country that built the first 30 of these centres, and they proved to be quite successful and were supported by local communities and by politicians. That's what they look like. There's a common brand. It's a positive, low stigma, trusted brand. It's in the main street it's in the heart of the community, so it's not hidden away at all. Everyone knows about it, and prime ministers love it. Every election, we were able to get the prime minister to kind of announce another 30 of these things, and because they got political mileage from it. They were able to do something for their community, and it was a positive story. It was about hope and optimism and looking after young people, and it didn't overemphasise the heavy clinical stuff. But nevertheless, these places have got doctors, psychologists, vocational workers, and drug and alcohol workers. It's a bit variable. We try to standardise it as much as possible with fidelity, but it is dependent on workforces and other sort of things, and local leadership actually is a key variable. But most of all, it's been the scaling up has succeeded, I would say. But it's only the first step. It's only the first step. The World Economic Forum, because of the economic arguments, that they realised that loss of GDP due to non-communicable disease, 35% of that was due to mental illness, and mainly because of the timing in life, of the life cycle. Cardiovascular cancer, that's more late life issue, so it doesn't have the same economic effect as mental illness. And so World Economic Forum were interested. We did a project with them, and it produced this global blueprint for youth mental health, including looking at low and middle income countries as well. So that was because of the economic argument. So, okay, the next phase. After 20 years, there was a fair bit of stasis, I would say. Things have slowed down a bit, despite the fact that the needs were getting more pronounced. And the advent of a headspace and a primary care focus revealed the extent of people who needed a much more specialised model of care. But then there's a massive bottleneck getting into the next level, because in Australia, the state governments fund the more specialised mental health care, and they underfund it. They only provide about half of what is really needed to them, even at the more severe end. So they couldn't get into the next phase, these young people. They had emerging psychoses or complex mood disorders or combinations, personality, drug use, all of these things, and they couldn't. Primary care wasn't enough. Short episodes of care. So we had to advocate for something to be done about this missing middle, the people who didn't need to be in acute residential care, but they needed specialised team-based care. So that's the missing piece. And so these people were stuck in a few missing rungs on the ladder, really, and they're really in no man's land. So last year, after probably about a 3-year effort, the government, the re-elected Albanese government, agreed to commit another $1 billion over 4 years, which sounds like a lot, but when you think that they're spending $52 billion a year on the National Disability Insurance Scheme, it puts into perspective. They've got their priorities wrong. There's a huge amount of money going to physical disability, and only about $5 billion in total from federal government into mental health. So the balance has to be fixed. And I think they're starting to do that. But anyway, it was a step forward, because they agreed to strengthen Headspace and also build 20 new youth specialist centres across the country. Now, it's not enough, but it's another tranche of building of the infrastructure. And models of care have been drafted. Headspace produced this model for Headspace Plus, which is for 30 centres that are going to be strengthened. So there's a couple of $100 million for that, and then there's nearly 500 for these new youth specialist centres, which Origin has designed the model of care. It's out for public consultation as we speak now. So it will start on July the 1st. So these are the documents that have just been released. And what it's going to do is, what is in this model of care is some kind of attempt to stream patients according to, evidence-based guidelines, probably a little bit syndrome-based, like whether it's for anorexia or for psychosis or bipolar or mood, complex mood, but also by stage, trying to structure it that way. And of course, there are going to be probably a couple of 100,000 young people in these structures altogether every year. So this is an incredibly research platform. We have access to these young people in the early stages of illness across the diagnostic spectrum, and they're coming into these systems of care. And what we're trying to do now, I'm nearly finished, so trying to build a research methodology into this infrastructure, which is going to allow us to test treatments in a much more flexible and dynamic way using this new technology of platform trials, and I don't know if it's going to work. I don't know if we're going to get the support or the money to actually build this in, but that's what we are trying to do. And this platform trial is like a new technology which is research as treatment, and it's re-randomizing patients to different treatment options in real time, not waiting for 5 years until the study's sort of completed head-to-head, but actually doing it much more dynamically. And this has been developed in COVID, during COVID, and in other areas of medicine to get answers more quickly and to test new molecules and new treatments, including psychosocial treatments. So that's what we're trying to do. But as I just said, who knows if we can actually do it? I mean, we're going to try, but we need a lot of support. We're working with people from other branches of medicine to help us to do it as well. So I'm going to stop there. Thanks, Robin.
So we need to invite Pat back to give a lecture on how to influence politicians. But it's a great talent. Questions, comments? Yeah.
Okay. Thank you, Pat, for this amazing presentation and also to giving testimony of what is that we do every day. I'm also the medical director of Youth Mental Health Service in Western Australia, and we are really into this. I have a few comments that are very important. Maybe a challenging question for all of us. Number one, why we struggle so much compared to any other part of psychiatry to recruit? Because this is one of the major problems in youth mental health. I can't find psychiatrists who want to work in youth mental health. It's a major problem, number one. Number two is obviously how do we lobby government and what will be the initiative and how to marry together public service, public mental health with the initiative, because obviously most of us say, well, why we don't get the public health also the same boost of, and we are really happy to work together with Origin, as you know, because we already have a few clinical trials. We got the most. That probably is worth to remember to everyone. We have this digital platform that we are already integrating in the day-to-day care.
Enough. Pat?
Yeah. Just on the workforce issue, the college has finally agreed. We set up a section of youth mental health in the College of Psychiatrists in Australia 15 years ago, and we've been trying to get a faculty and alongside the child and adolescent one. And they've now approved an advanced training scheme, so you can do it as a higher training option. And so I think that will actually help that issue. But you're right. I mean, the problem is how you stop people going to private practice. How do you stop the hemorrhaging of people being trained in the public sector and leaving the public sector? Because You can work in Headspace and these new centres as a contractor, but you have to bulk bill. So there's a financial issue, so that's probably one of the key drivers. But I think the government is shifting to more salary-based models, but they have to be properly paid and the conditions have to be good if we're going to keep people.
So any non-Australian questions?
This isn't a non-Australian question, but I'm the next up, so I'm going to ask or going to make a comment. Greg Spice from Australia. I work in mental health, and I've worked in Headspace. I notice, Professor McGorry, that when you listed possible causes and the question of why mental health in youth is deteriorating, and there are about half a dozen groups of possible reasons, you neglected to actually add the profession itself and the tendency, in my mind, for the enfeeblement of the people that we supposedly attempt to provide care for. And the teams that surround these supposedly newly pathologised young people, or even not young people, generally the people that we see from day to day. Yeah. And it's like the old leprosariums, you know. You couldn't kill off the leprosy specialists in WHO for years after there was no need for them. Because they'd become part of the system. They'd become an institution unto themselves. The teams that surround people, young people included, and I've seen it particularly in Headspace, where there's pathologising of the poorly parented rather than perhaps some sensible, more sensible rather than overweening care, more sensible advice to be offered to them rather than overweening care, because it's in the interests of the team to keep pushing people through. And indeed, in Headspace, I noticed most people were being pushed through to the early psychosis stream because that's where the money was, that's where the funding was.
Well, obviously respect your experience, but it's completely different to everything I've seen in Headspaces around the country. And in fact, Headspace is a very light touch. It doesn't push diagnosis. It's very much in the background. They're very brief episodes of care. So I think your analogy with leprosariums is a bit off, to be honest. My dad was a TB doctor. He worked in TB sanatoriums, and they disappeared almost overnight once streptomycin appeared. So I actually disagree. And what I find working in, and I still work in Headspace myself, I get to see the more complex people who absolutely need very intensive and comprehensive support, which they can't get. It's the opposite of what you're saying, actually. So I don't know where you're working, but I'd be happy to talk to you afterwards.
So any non-Australian questions? Anton.
Hello. First of all, thank you for the talk. At WHO Europe, we are trying to form a policy and harmonization of approach for youths, and we have a lot to learn from you, so thank you. At Headspace, if someone develops very serious mental illness, would they still be followed up at Headspace eventually, or be referred to other service? I'm talking of severe psychosis, severe anorexia, these type of things.
Well, my experience of that and the pattern that we see is that maybe about 40% of them have got more persistent or like a brief episode of care. I mean, the average number of sessions in Headspace is about 5 or 6, you know. So it's like primary care. But the problem is there's nowhere to refer them to, or it's very, very difficult to get these patients into state services, like Ettore was saying. You know, they're underfunded, and their whole rationale is how do we keep this patient out of the service? You know, because they have to, because they're under-resourced. So these people are stuck in this no man's land I was talking about, and we would do our best, say, within Headspace or the GP. Most young people are still treated by GPs, not in Headspace. So that primary care level, breaking through, and this is what parents all around Australia are struggling with. They cannot get their kids into the right level of more specialised care, and that's what we managed to convince the government to begin to address with these services. And so, picking up on the last one, I actually agree we shouldn't be heavily labelling or making a career or pathologising. We have to say to these young people that you can get better and you will not need long-term care. That's the message that we should give them, but we've got to be able to deliver on that then.
Great. Thank you so much, Pat, for this breathtaking presentation. It was incredibly valuable. Thank you also much for dwelling into the reasons why we see this huge increase in mental health diagnosis or problems. I much agree that it's definitely not biology. Definitely not genetic. Your point is that it might be sociological factors. When I look in the Netherlands, where we have currently a 48% of the population who have at least one psychiatric diagnosis, I'm not so sure if it's sociological factors, because Netherlands is not doing all that bad. So social inequality has rather decreased than increased, and even climate has been worse 10 years ago. So what about psychological factors rather than sociological factors? Perhaps for the newer generation, it's okay to be vulnerable and it's okay to reach out for help, while in the older generations, perhaps it wasn't. You had to solve your own problems and maybe suffer in silence. And maybe this actually is a good thing, that young people dare to reach out for help, and we just need a new way to answer that question, which is not the old way, like we did with the previous generation that was seriously ill when they reached out for help.
Yeah, well, that goes back to the other point, that if you get people in that early stage and maybe simple interventions, the staging idea, you don't need to use medication, or you just need to sort of deal with the pressures or the stressors that they're dealing with. That's a lot of what happens in Headspace, actually. Yeah, I don't know. I mean, I don't actually know why. I can't really be sure about what the factors that are causing this rise in mental ill health actually are, and it could be. That's why I brought up that prevalence inflation idea, that maybe the bar has been set too low, you know.
Exactly.
And there is some of that, you know, but I think the methodology of some of these other surveys is strong enough to show there's a real increase as well. And it'd be interesting to see what the right methodology to answer the question would be, you know, because we can all have opinions, but how do we scientifically sort of answer that question?
Indeed.
So,
and then just one last comment to the employment. So how do we find the people for these first contact treatments? I think AI would be our way to go.
Well, AI is a thing called MOST, which Ettore mentioned. It's a digital platform that's been developed at Origin. There's 150 people working on it. It's in 5 or 6 states, and that is building AI with Wellcome Trust funding into the front end of that too. So maybe that's one way. Yeah.
Pat, in your list of, it's me, possible causes increasing this, you mentioned that you might have forgotten one. Would you like to say which one you might have forgotten?
Well, I suppose you just try to look at the sort of things that have happened in society over the last 20, 30 years. And I've got a grandson now, and he's spending most of his life in childcare, you know, and that wouldn't have been the case 30 years ago, because both parents are forced to working. And so the child's attachment is definitely being affected by that. Now, I looked at the evidence on this, and it's a bit mixed, you know. And obviously there's, you know, political dimensions to looking at that even.
Pat, who is asking you this question? What you need to...
It's about cannabis, Pat, but I would
Oh, sorry. Oh, well, okay, that would be one, yeah. But I don't know, has it gone up in Australia? Has it gone up in all countries, or is it just countries where it's been legalised?
Well, cannabis consumption has gone up in most countries.
Okay,
I'm not just cannabis, drugs in general. But anyway, that's my...
that would be one we left out, yes. Yeah.
Hi, I'm a child and adolescent psychiatrist. I've been doing it for about 30 years. And I honestly agree with the Australian speaker, the first Australian speaker, I'm afraid I don't know what your name is, that we are complicit with this increase in youth mental health problems, and that broadening the base of the pyramid with the least skilled workers is advertising mental health problems to children, and that vulnerability is not a good thing necessarily. We are increasing people's ability to be vulnerable, to be unable to go to school, and we are accepting all that. And it's damaging young people. And there is a lot of drug use as well, which is also pretty acceptable in our society. But we, by funding these sort of essentially low-grade mental health, sort of mental health light places, we're not paying for real psychiatrists to work. And those real psychiatrists at the top are getting millions of referrals because we've broadened the base of the pyramid. So it's impossible for them to do their work. They can't. It's just too busy. So we need to do something really different, and I do think the tide is turning. I also think it's a fashion. There's a certain amount of fashion in mental health that's been fueled by social media. So all the things you said were correct in your talk. I think broadly socioeconomic change, all those things. But I'm seeing posh kids in my NHS clinics. These are kids with parents who are 2 lawyers or 2 doctors, and they are really struggling with quite sort of major mental illness that has come out of kind of nothing, really. It's not that they have a mental illness trajectory. It's a sort of behavioural thing, and we're treating it in a different way from the way we treated years ago, and we're advertising self-harm and mental illness. So that's what I think.
Yeah. Well, I can see the point that, and that's what I tried to say about there's a side effect of too much awareness, right? So, but I've got to strongly disagree. I mean, practically speaking, when you look at the volume of people that need help, and if you don't provide that soft entry, that easy way in, you get long delays in people who are developing, definitely severe forms of mental illness, and that's incredibly damaging. And the other point I want to make is that you're never going to have enough psychiatrists for the psychiatrists to be the front line. It's just mathematically impossible for that to occur. So you have to have a primary care level of care for these young people. What's your solution without that?
I think it will change because I think it's a fashion, partly.
It's not a fashion. I see these people every day.
Well, so do I.
It's not a fashion.
I think it would be good. I mean, these are great discussion. I have to say, you can see both sides, but I, as a clinician in London, get often friends who can't access specialist services and don't have services like Headspace in Australia, who ask me, what do I do with my teenager's daughter? And so there is an increasing group of teenagers who have nowhere to go unless they are on a waiting list for a specialist service. So I think the work you're doing, Pat, is something we can learn for. And as you said, there might be things can be changed, improved, adjusted, but I don't think removing Headspace is the solution, because I think there are these people, young people out there that need help and support, and families that need to have somewhere to go. So I'm really grateful for the work you're doing, particularly living in a country like UK where youth club have gone as well. So there's nothing, there is not even the street anymore. There are bedrooms where these children are, or highly specialized services, and there is a big vacuum in between. So thank you very much.
Yeah, thanks. Yeah, thank you.
So thanks, Pat. I think we haven't had enough arguments at this conference, so thank you very much for provoking us. Do we have? Is it now coffee?
Yeah, now it's time to calm down with caffeine and cakes, and then please be back on time. You know your way around coffee and everything else.
Would it be possible to get a copy of Prof. Cleary's depression slides from yesterday?
You get everything.
of psychiatry. I had the pleasure to collaborate with Giovanni since the time we were young psychiatrists. We still think to be young psychiatrists, but of course Giovanni has developed throughout his career lots of experience in clinical research, and we share today some of his data on bipolar, on party drugs and youth mental health. So thank you, Giovanni.
Thank you very much, Diego. It's a pleasure and an honor to be here. Thank you very much for your words, for your introduction, and thank you very much for this opportunity again. And during my presentation, I'm going to speak about party drugs, and I'm going to do some discussion also correlated to the previous presentation regarding youth mental health. This is my conflict of interest, and this is the agenda of my presentation. These are our topics: NPS, CLEP drugs, and the risk of psychosis, the issue of violence and chemsex, and also the roles of psychoactive pharmaceuticals that are commonly used for recreational purposes. And if we have time, we will also mention the role of GLP-1 as performance and image-enhancing drugs. Let's start from the point that the members of the Gen Z are less likely to describe their mental health as excellent or very good. During the last presentation, Professor McGorry has emphasized this point, and in comparison with the other generation, like that of the boomers or the millennials, the perception of the quality of life in terms of mental health is quite different. If we look at different surveys about this, for example, this is coming from the American Psychology Association, 37% of the Gen Z report seeking help of treatment from a mental health professionals. From one end, this could be a good point because it means that the stigma is less than in the past. But from the other end, of course, probably it means something, with anxiety and depression at the top list of problem themes. And trying to explain these, looking at, for example, what philosophers are saying and sociologists are saying about this, I would like to report Byung-Chul Han, a philosopher that described this society as the society of achievement, where productivity can be seen as a duty, and the subject of the achievement society is the entrepreneur of the self, and where self-exploitation is accompanied by a sense of freedom. And always with Byung-Chul Han, some other reflection about our societies. Here he described the society without rituals, and I would say also without roles. So with the absence of socially shared and historically rooted rituals that can help to afford some specific situation of passage, from example, from adolescence period to the adulthood, but also in other period of the life of every single adolescent. And but can we explain this only with the prevalence inflation hypothesis? Professor McGorry described this possible explanation regarding the fact that the adolescents today are in a situation of difficulties with regard to mental health. Could be this point explained by an improved recognition of the diagnosis, for example, of the increase of self-diagnosis and the presence of false positives? Of course, this could be an explanation, but on the other hand, looking at concrete data for example, if we speak about suicide, we are not speaking about tendencies and false positives. The trends in terms of suicide rate is something that is increasing in the last few years. And this data is something that is specifically correlated to teen girls. This is the point. If you look at suicide rate change since 2003, you can see that this increase can be explained by the rise of suicide rate in female teens. So this is a point. And we are not speaking about the sensation of having a bad mental health. No, these are suicides. And trying to propose some possible models, some possible explanations regarding postmodernity, one concept could be that of the individualization and also that of the commodification, that is another characteristic of our society. Another point that, from my point of view, is very important is the horizontalization of the culture. Today, it's very difficult to have a close relationship with grandfathers, for example. We are speaking with peers. It's very difficult to have an exchange in terms of knowledges and so on. So the horizontalization of the culture, the changes in social roles, the changes in the nature of identity, and also in the nature of the intimacy with oneself and in the relationship with the temporality. So if we look at this collapse of the meta-social guarantors and structured social life, we can have at a point like the dissolution of the authority and also the role of the individual performance. Everything is confined to the immediacy of the moment. Adolescents are hostage by an eternal present with, in some occasions, with a sense of unreality. They are unable to wait. They are heightened states of excitement in some points, and with dysphoric mood, which is another characteristic, and another very important characteristic is that of the presence of anger and impulsivity. But I do think that most of these things can also be determined by the use of substances. I do think that psychoactive substances can become powerful catalysts, intensifying the experience of timeless gratification. So in my view, one of the most important points that can explain the high level of suffering of this generation can be explained by the use of substances, by the use of cannabis, by the use of potent, novel psychoactive substances. So this is a point. We need to take into account that the use of substances is increasing, and most of all, the potency of the substances is dramatically increasing every year. And this is the issue. The new substances, they have a significant psychopathological impact with dissociative effects and increased risk of aggression, interpersonal violence, and other specific factors that we are going to describe during this presentation. When we are looking at substances, first of all, we need to try to differentiate among them stimulants, empathogens, psychedelics, dissociatives, cannabinoids, depressants, opioids. All of them can determine some specific dissociative states and in some way can alter mental health. And if we look, for example, at the trend that we have at the moment, actually we can see that in the last few years we have a high development of the level of cannabinoids, specifically synthetic cannabinoids, but also other stimulants like the catechinones and piperazines and other substances. And the reason behind this, in most of the sample that is possible to analyze, is to get high or for fun. This is the reason behind. They are trying to use novel substances with a higher level of potency. And if we give a look at the seizure of new psychoactive substances in the market, for example, this data is coming from the European Union, but it's not that different from, for example, Australia and other continents. You can see that, for example, catenones are very relevant. 3-CMC, for example, is this one, 3-chlorometcatenone, that, for example, is a new psychoactive substance that is very popular at the moment, that is structurally related to methadone, technically speaking, is a stimulant, with the mixed stimulant and tactogen profile, but less serotonergic than methadone, for example. And if we look at 3-CMC, the risks are that of agitation, hyperthermia, and psychosis as well. And other kind of catenones like the 2-MMC or the NEP, with the cocaine-like stimulant profile, with the high risk of paranoia, agitation, and psychotic symptoms. But why newer synthetic catenones may induce more psychiatric complication than methadone, for example, which is probably the most well-known catenone? This is because they are changing the dopaminergic stimulation. They are increasing the level of the dopaminergic stimulation. Why this? Because this is more rewarding than having a lower dopaminergic stimulation, just to get high, as I was saying before. This is the reason why newer catenone can act specifically on dopamine and norepinephrine with a higher level of activation and a lower serotonergic modulation compared with methadone, for example. So we have a greater stimulant-like profile, and in terms of clinical symptoms, we can have increased agitation, paranoia, impulsivity, and stimulant-induced psychosis. The other characteristic is that of the short duration with the repeated dosing and the rapid escalation of intake, and of course, the increasing number of acute psychiatric presentations. This is the diffusion of NPS in the world. You can see some specific countries where this is mostly represented, and then there's another point regarding the use of new opioids. Nitazens, for example, have becoming more and more popular. Of course, here we are in another class of substances. We are not speaking about stimulants, but we are speaking about opiates. And this regarding nitazens is another issue, because this is an emerging ultra-potent synthetic opioid, and with a very high potency. They are very easy to synthesize and modify. They are very cheap to be produced. In many cases, they are mixed with heroin, fentanyl, and other pills, other products, with a very high risk of fatal overdose and respiratory depression. And so this of the nitazens is another issue that we have to take into account. In this review, we try to describe, of course, the interaction between these substances and the risk of psychosis. Then another point, another phenomenon that I do think is very important is that of chemsex, that is becoming more and more popular in Europe, in Australia, in the US. This term derived from the expression chemical sex, of course, and it describes the voluntary use of certain psychoactive and non-psychoactive drugs in the context of parties and sexual encounters. It's becoming more and more popular. These are the most common substances utilized during a chemsex experience. So we have the methadone, and specifically those kind of catenones that I have showed some slides before, with the 3-MCC, probably at the higher position, but also the GHB, the gamma-hydroxybutyric acids, that has depressant effects, and the methamphetamine and poppers, that are compounds containing amyl nitrite. Most of the cases, altogether, from some respects, we can have a stimulant effect. Other substances can have a depressant effect that can counterbalance the stimulant effect. So they are using all together, and in many cases, we have psychotic experiences. They induce a general sense of relaxation. These drugs can intensify arousal and sexual desire. Of course, in many cases, we can also have medical issues with the increased risk of contracting sexually transmitted infection, of course, and in terms of psychiatric consequences, we can have psychotic reaction. Until now, I have reported the data regarding new psychoactive substances, but on the other hand, we need to consider that old vintage substances are increasing in terms of potency. And I'm not going to speak about cannabis, of course, because Marta and other colleagues will discuss about this point, but cocaine is a vintage trend that is increasing and increasing year by year. For example, here, look at the purity of cocaine. In the last few years, the purity of cocaine is increasing. The price, more or less, is remaining there. And this can be connected to psychotic reaction as well. Look at the diffusion and purity of cocaine. The cocaine market in Colombia and Peru, the number of the cultivation and plantation is increasing. It's still a very good market, that of cocaine. And also because cocaine can be combined with other substances. Crack cocaine and heroin is the famous speedball with some specific effects, combining the stimulants and the depressant effect. But we also have crack and cannabis together, with the cannabis that is used to ease the down phase sensation, and the use of crack and amphetamines with similar effects, but with some specific differences that can be proved together. So the utilization of cocaine is becoming more and more common. And then the other point is that of synthetic cannabinoids. Synthetic cannabinoids is something that is misleading in the definition. We could say that they are not cannabinoids. Of course, if we look at the chemical structure, of course here you can see that they have a specific chemical part that is connected with the CB receptor, typical of the cannabis, but this is just one of a specific part, but we also have a specific 5-HT ligand and the NMDA antagonist part, and here we have the fluorination. Why this? Because when we have the fluorination, the molecule can pass the blood barrier in an easy way, in an easier way than without the fluorination. So synthetic cannabinoids is a sort of polysubstance per se, because we have different actions. That of the cannabinoids is probably the less important. In terms of synthetic cannabinoids, we have the highest percentage of psychotic reaction that we can observe in the clinical practice. But are these NPS, novel psychoactive substances, and these modern and more potent substances really able to induce thought disorders? And most of all, are these transient psychosis or the beginning of a chronic disorder? This is the point, and in many cases very difficult to understand since the beginning if we are going to a direction or to another. And when we are in front of, for example, in our clinical activity, in front of a psychotic episode at the beginning, we are always thinking, but how is the situation going on? Is this something that is going to be something that is can become chronic or not? We know that approximately 25% of individuals with substance-induced psychosis go on to develop schizophrenia, and this is a point. we know that cannabis use determine worse outcome of psychotic disorder in terms of positive symptom severity, relapse rate, and number of hospitalization. This is a sort of new epidemic, that of cannabis, but the other point connected to psychosis is that regarding the methamphetamine-associated psychosis that is very, very common. In Australia is a dramatic issue, but also in other countries, also in Italy, in the Southeast Asia, and it's very common. More than 76% of methamphetamine users experience a paranoid psychotic state with hallucination, 2/3. And it is interesting that, for example, the MAP, the methamphetamine-associated psychosis, has 3 phases: an initial one with psychotomimetic effects, and then a pre-psychotic phase with emerging delusional ideation, and then a full-blown psychosis with hallucinations and referential delusions. But going in details and looking at the transition data, for example, we know that this is a very relevant study. We have many similar studies, but this is the most important, a prospective study about the transition. Almost 7,000 inpatients with a diagnosis of substance-induced psychosis without a previous history of schizophrenia, bipolar disorder, or other major psychiatric issues. And after a period of 5 years, overall, 1/3, 32%, of patients with a substance-induced psychosis converted to either bipolar or schizophrenia, so converted to a chronic disorder. And if we look at the different substances, the one that is doing in the worst way is cannabis. That is probably the most relevant substance, together with methamphetamine, in terms of transition to schizophrenia from the psychotic episodes. So if we are in front of a patient in our inpatient unit, which are the factors that can drive the diagnosis to a classic psychosis like schizophrenia, that is in the future will transient to schizophrenia? For example, the early age at onset, the higher level of positive symptoms, the greater prevalence of auditory hallucination, the poor insight, and of course the positive family history of psychiatric disorder. And on the other hand, who develop a transient psychosis that is going to return to the previous state, when we have the greater prevalence of visual hallucination, with the disturbances of consciousness, the presence of suicidal thoughts, with violence and aggression, with greater insight, with lower levels of positive symptoms, and with the family history, of course, of substance use disorder. So these are some clinical characteristics that can help us to understand if the state that we are observing is something that is transient or not. So this kind of substance-related exogenous psychosis can be considered as a new form of schizophrenia in some way, because in many cases it's something that is transient, but in other cases it's not transient, but it's not schizophrenia. It's something in the middle. So it's something new from the clinical point of view. It's not just a substance-induced psychosis, a sort of toxic psychosis that appears during the intake of substances, but it's something that can persist far beyond the last substances take. So it's a sort of chronic syndrome, and that in some way can be clinically and phenomenologically differentiated from the classical model of schizophrenia. If we try to use a visual representation of these in the classic schizophrenic psychosis, we can observe something that is moving from specific alteration, like the alteration of the basic structure. But when we are in front of a substance-related exogenous psychosis, is something that is mostly determined by something coming from outside, like the use of substances that's going to alter the situation and determining the psychotic concept. So if we try to see again the classical psychotic patient and the postmodern psychotic patient with the use of substances, we can have some differences. In the endogenous schizophrenia, is more related to thought, the sense of detachment, the presence of perplexity, some specific delusions, the sense of passivity, bizarre behaviors, autism, and then the clear consciousness and lack of insight. On the other hand, something that is more related to perception, excitement, instability, but also loss of control and aggressiveness, and twilight consciousness and partial or total insight. And again, some specific symptoms. One is very important. In many cases, we have ego dystonic experiences in substance-induced psychosis. And to this respect, for example, Henriet described the hallucinatory delusion that is coming after the use of substances. So starting from the beginning, the psychoactive substance can induce hallucination, then hallucination can alert the subject. In the first phase, hallucinations are referred, because this experience is ego dystonic, to be caused by the substance. Then we have the transitional states, flashback phenomenon, and then the subject start to interpret and make connection among hallucination and relationship between them and the world. And then at the end, we have the paranoid development, a sort of pseudo schizophrenia. So this is the passages that have been described by Henriet. And then the other point is the presence of impulsivity, aggressiveness, and violence. This is very common, and in most of the cases we know that substance use is associated with episodes of aggression with injuries committed by a psychiatric patient, and this is very common in this new form of psychosis. And to this respect, Sina Fazal from Oxford described the very important role of substance use as probably the most important factor associated with interpersonal violence. And this violence, this presence of violence is very common with NPS. For example, reported use of NPS was strongly associated with violence pre-admission and during admission in general hospitals. And to this respect, the use of cannabis, the potent cannabis that we have available at the moment, and I would say the synthetic cannabinoids as well, are strictly connected actually to the use, to the presence of violence and violent behavior and interpersonal violence. Another substance that to this respect is very relevant is MDPV, which is the cathinone 3,4-methylene-deoxypyrovalerone. That is probably the substance with the associated highest level of aggressivity and violence, and violent crimes associated. And for example, we have also data regarding this substance in custodial settings, and the MDPV is also associated with mechanical suicides. So we are speaking not only about violence, interpersonal violence, but also with suicides, which is also another form of violence, if we can say this. And so we received many points regarding the MPS, and the potent substances that we have available at the moment. But another issue that in many cases is not well described is that of the use of prescription and non-prescription drugs in the context of MPS. And we have the example regarding many over-the-counter medication that can be utilized as NPS and mixed together with other substances. For example, here we have some examples of common pharmacotherapies that we know, for example, gabapentin and pregabalin, but also some antidepressants like venlafaxine and bupropion, quetiapine, and zeta drugs like zolpidem. We know that these drugs, if we are using these pharmacotherapies at the right dosages, probably they are not determining some rewarding effects. But if we are using, for example, venlafaxine at the dosage of 500 milligrams per day, we have a very potent dopaminergic stimulant. It's like taking methadone. And the same is for gabapentin and pregabalin. If I'm going to use gabapentin at the dosage of 3 grams per day, the pharmacodynamic is completely different from the pharmacodynamic of a compound that can have anti-anxiety effects. So the use of this substance is very common also in custodial settings. For example, the use of gabapentinoids. And after the use of gabapentinoids, we can have altered state of consciousness also with psychotic states determined by the use. So if the patient is asking for too much gabapentinoids, we have to try to think if the use is the right one, or if the patient is diverting the use of gabapentinoids.
Giovanni, our dog takes gabapentin for pain, and vets have to be very careful now in UK because owner of pets request excess prescription for self-use.
Good to know.
When I go for a repeat prescription, they sort of count how many they've given me before and if I have really completed the previous.
Good to know that also the vets are aware of this.
No, at least our vet is aware.
Okay. But because it's your vet, probably. Okay. And that of quetiapine. Quetiapine is another substance that is at the highest level in the market of the custodial settings, for example. And the dextromethorphan, yesterday Professor Fagiolini described his possible role as a new antidepressant in the future, but at the moment we also have many data regarding possible toxicity due to the specific NMDA effect that can be enhanced by the use of high quantities of dextromethorphan. And then, of course, codeine, cough and cold medications with, of course, calming effect, but combined with promethazine, we had the purple drunk. That is a specific drink, very common in adolescents. It's used, but it's also associated with coma and death, and tolerance and dependence and psychotic effects as well. And loperamide, you know that for sure. But of course we are using one pill in some specific cases. But if we are using 10, 15, 20 pills, we have a sort of cheap methadone, low highs, poor methadones with CNS depression and some rewarding effects, but also fatal cardiotoxicity. And another point, for example, is loperamide cannot be determined in the standard urine drug screen, and this is an issue, for example, in custodial settings and in other specific contexts. And then the last part of my presentation regards another very popular point is that of GLP-1 receptor agonists, glucagon-like peptide-1, that mimic the action of the endogenous hormone, and which is released in response to food intake. We know the pharmacodynamic effect. Of course, due to their role in promoting insulin secretion, inhibiting glucagon secretion, and delaying gastric emptying. And these medications are commonly prescribed in diabetes type 2. But these are the well-known in Europe, UK, United States, the semaglutide, the tirzepatide, very, very common. They are approved and so on. But on the other hand, we need to know that GLP-1 receptor antagonists are increasingly be used off-label as PEDs, performance and image-enhancing drugs, particularly, of course, for weight loss and body composition purposes, rather than their original indication. How many patients are using these products? In many cases, could be a good idea because, for example, I have good example of patient with a chronic psychotic disorder taking clozapine, taking olanzapine, and also taking GLP-1 with very good results. So I'm not saying something that is 100% bad regarding this use, but in many cases we can have this use in cases of body image concerns and other possible with other possible motivation. PEDs are a specific characteristic of a group of substances also called lifestyle drugs, which is a sort of an umbrella term that describe products taken to improve human attributes and capacities. This is something that can be related to the beginning of my presentation regarding the change in the society, the society of the achievement, and that of taking something that can improve the way my image can be something that is going in that direction. So many children are also thinking about taking GLP-1 products to improve their image. And, but we know that, for example, we have possible association in terms of pharmacovigilance, because GLP-1 receptors are not neutral in terms of interaction with the hypothalamus, hippocampus, amygdala, and with the interaction with the neurotransmitter systems, including serotonin, dopamine, and glutamate, specifically at the highest dosages. So this is a point. They can have a critical role, and I do think that we are still at the beginning. Because, for example, this is a very interesting in silico study looking at the pharmacodynamic interaction. And we know that we could hypothesize that in the short term, where hyperdopaminergia exists, the stimulation of GLP-1 receptor can promote the downregulation of the dopamine signaling. And this can be good because we can have some reduction in the food intake and also some reduction in the use of alcohol and substances, because I am determining a downregulation of dopamine signaling, so I can reduce the craving. So from one end, this could be very good, but on the other end, this can be a sort of double-edged sword, because it can potentially trigger anti-addictive effect, but suicidality that can be determined by exacerbating depressive phenotype. So, I mean, I do think that for sure GLP-1 will be the future of pharmacology and probably of our society as well in terms of market diffusion, but I do think that in many cases we have to use this product with caution, and we need to consider that in many cases they can determine some specific issue, and also that of the, I would say, addiction to this product could be another point, probably. Of course, we are still at the beginning with the development of these drugs, but we need to take this point into account. And then, in this afternoon, in my talk regarding the workshop that we have in the afternoon, we will discuss about the pharmacological treatment of these acute substance-induced psychotic states, but we will discuss as well the use of antipsychotics and antidepressants in dual disorder condition, and then we will try to say something about the management of aggression and harm reduction. And with this, I conclude, and I thank you very much for your attention.
Thank you, Giovanni, for taking us through all the new substances, and also for bringing some new insight. For example, I never thought about this fact of the downregulation of dopamine receptors as a consequence of chronic use of GLP-1. I just was wondering if what happens when then you discontinue then the GLP-1.
Yes, of course, this is a point. Also, I wouldn't say that this is an issue with the low dosages, but where you are using 15 milligrams of Mounjaro, for example, at the highest level, at that point, the interaction with the dopaminergic system is something that we need to consider.
Is any questions for Giovanni?
While people warm up, it's interesting, Giovanni, what you said about the GLP. Sorry, Robbie, you had a question? GLP-1, because recently I listened to a talk by Nora Volkov, that, as you know, is a queen of addiction, who is actually bringing together evidence suggesting that GLP-1 could be, in fact, a treatment for substance misuse. And again, it's always the issue how, when, and for whom you use a substance. But I thought that was another very interesting perspective of the interaction of GLP-1 with dopamine.
Yeah, because we have data available regarding specifically the reduction of the use of alcohol in subjects taking GLP-1. But this is true probably for the general population and not for those cases with the addiction issue. But it's an area that is very interesting. Also, it's a double phase, I would say. We need to study the phenomenon.
Yes, I was just going to ask for some elaboration on that, because there's large studies now from, I think, Washington University, a very large epidemiological study of more than, I think, 600,000 people, and then an all-Danish or Scandinavian study showing major reduction in use of illicit substances with those on high-dose GLP-1 modulators, even including reduction in suicide. So I guess we are getting some data from larger studies. Just wondering about your comment on that.
I'm in favor. I've seen that studies. I'm in favor of the possible use of GLP-1 products, but I do think that we are still at the beginning, because the data that we have available are not going in a period of a long period longer than 2 years of observation. So I would say probably we have some good reasons to think about a role of GLP-1 also at higher dosages, but we need to understand which one of them, for example, because the new one, it seems like they are doing better than semaglutide, for example, that at the beginning had some issues in terms of suicidality, in terms of pharmacovigilance. So I do consider this study, and I do think that there's space for some therapeutical use, but I do think, again, that we are still at the beginning.
So I like your review of the party drugs. It's amazing, the continual novel substances. You used this term endogenous schizophrenia, and I wondered where this comes from. How can, I mean, say, or forgetting about whether schizophrenia exists or not, how can it be endogenous? They must have a cause.
Okay. Yes, of course. No, I use the term endogenous to make a comparison with the exogenous in terms of something that is determined by the substance that is coming from outside.
Like child abuse. Is it endogenous or exogenous? Or social adversity or migration? Are these endogenous or... No, you excuse me.
No, of course, I understand the point. Of course.
This is another hobby horse.
No, I understand the point, probably it's endogenous.
I'll let you go back to the topic.
Professor Murray, as you know, is the editor of Psychological Medicine. One of the things he likes the most are scientific, you can call it argument or disagreement of discussion. So whenever there is a paper that is controversial, he loves it. And he goes around hoping that people are going to write letters disagreeing or expressing different opinion. So you can see today he's picking up on the spirit of the morning. So sorry, Giovanni, I apologize. No. Next question. I thought there was a question there. Yeah.
Hi there, I really enjoyed your talk, thank you. I have a very quick question, just a clarification one. You mentioned about a quarter of those with substance-induced psychosis kind of get schizophrenia, and over 5 years there's a large percentage, about 30% I think you said, that developed bipolar or schizophrenia, was it that they continued using, or was it just after that one episode?
After the interruption. So in that sample that I have mentioned, so they had the psychotic onset, then the inpatient unit. After that, without the use of substances, they still have the development, the transient phase. So probably if they would have continued to use, probably that data would be higher, would have been higher.
There is a study from the Danish registry suggesting as well a conversion rate of 40% in those who don't necessarily continue. What is not clear from the Danish rates, if it is after a fast episode and people stopping, that then you have a conversion rate of 40%, or does it also include people who might have, after the fast episode, continued to use for a while, then stopped, but nevertheless have not recovered? So it's not clear if there is a timing, if you like, effect. Was there another question?
I'm just thinking about the conversion rates from crystal methamphetamine usage. The association of cannabis with psychosis is quite well known. I have great difficulty in getting early intervention in psychosis services, not martyrs, but others, to accept patients who've developed psychotic symptoms in the context of crystal methamphetamine use. Because we hear things like, it's just crystal, they'll get better, they don't need support ongoing. I find that quite frustrating. And I wonder how we disseminate your knowledge with our colleagues to help us get better access to treatment for our patients.
Crystal meth psychosis and I would say stimulant psychosis are very difficult to be treated. I would say that the data in terms of conversion rate is right behind that of cannabis. If cannabis is almost 50% the conversion rate from psychosis to schizophrenia, that of crystal meth is the one that is right behind, the 42, 43 doing an average with the different studies. And the possibility to treat this situation is probably more difficult than of treating cannabis psychosis in my experience. In many cases, also interrupting the use, symptoms are continuing and it's very difficult to treat. We have to say that in Italy, crystal meth are not that common as in other countries. But when we have these cases, is one of the most difficult situations that we can have in our units.
So just to comment on the question, that there are some Japanese studies on methamphetamine psychosis showing that people who took a lot of methamphetamine went psychotic, then stopped, and 5 years later encountered social adversity and they go psychotic. And so the suggestion is, have they done something to their receptors? And there's one study by Chalky Benlifat and Isabel Bolio from McGill, where they took 12 healthy men and they gave them amphetamines on 3 occasions over 21 days. And each time they gave the amphetamine, well, they gave, I think, intravenous amphetamine, they measured the dopamine response and the behavioral change. And each time it was bigger. So instead of getting habituated, they got sensitized. And a year later, they thought, well, we better just check to make sure they've gone back to normal. A year later, they gave the amphetamine, it was even a bigger response. So suggests that sometimes you do meet these patients who say, oh, I used to take lots of drugs in my teens. Then I met this girl and she said, I'm going to dump you unless you stop. And then they go psychotic 5 years later. And you don't really know whether it's got anything to do with what they took in their teens or not.
This of sensitization with stimulants is very common with crack cocaine as well. If you have a crack cocaine psychotic episodes at the beginning, also if you are using again a very low quantity of crack cocaine, again you are having the episode. So the sensitization is something that is typical with methamphetamine and stimulants specifically. Who knows why? Difficult to understand, but it's a clinical issue.
I
do you ever have concerns that our focus on drug-induced psychosis is unfortunately but inadvertently leading many colleagues to overdiagnose it, leading to people being actually disenfranchised from service access? I do see that, unfortunately. So people come into prison who have been involuntarily admitted, many times in the previous 2 years, and each time they're given this diagnosis of drug-induced psychosis, even though oftentimes there's not even been a urine drug screen. But I think there's a tendency to think clinically that actually you can become very good at clinically differentiating these acute presentations. My experience is that's a road that we should not encourage people to go down, because I think it's leading to misdiagnoses and people having terrible outcomes who genuinely have primary psychotic disorders but happen to use drugs also.
May I add? Go, Giovanni, yes.
Please, no, vai, Diego.
No, that's a very important point, especially when we talk about methamphetamine. So, in general, what we call drug-induced psychosis, we need to consider that the intoxication phase is very risky and is very dangerous. So, the importance is not only thinking about developing a chronic psychotic disorders, but also to interrupt the cycle of intoxication going to psychiatric hospital, perhaps intensive care or in prison, because that phase in our experience, and we'll talk at the psychiatric intensive care session this afternoon about that, this carries a very high risk of harm to other people or harm to self-harm. So, important point, definitely.
I do agree that overdiagnosis is an issue with the substance-induced psychosis. Of course, substances are complicated our capacity to do correct diagnosis. This is a point, and in many cases, it's not a schizophrenia episode. It's not a psychotic episode. It's not schizophrenia. It's something different. With substances, we are facing these issues.
Thank you very much for your presentation. It was very clear. I'm wondering if you have any data regarding the use of benzodiazepines, street benzos, and psychosis. I work in the Republic of Ireland. We had a few presentations a couple of years ago of benzodiazepines, street benzodiazepines induced psychosis.
At the moment, we have some NPS, some benzo NPS that are very, very potent substances. These are not common, for example, in places like Italy, where benzos are very, very commonly used and very freely available. If you go in a pharmacy here in Palermo, you can get benzos without any issue. This is an Italian problem. In other countries, benzo NPS are more common because it's not easy to, for example, in the UK, to get benzos is not an easy task. But many of these benzo NPS are very, very potent, and in the literature we have different cases of psychotic episodes, probably because of very high dosages, specifically also the zeta drugs, they can induce some psychotic phenomena.
Thank you very much,
Okay.
Giovanni.
Thank you, Giovanni, for the presentation, and everyone for the very enriching discussion.
Well, it was very good that the last question was about benzo, because we are entering in the world of sleep. I hope not for you, because the next speaker is, as you know, when I do the program, I think, what would I like to learn when I come to the forum? Given that, unlike you, I cannot go for a walk, I usually listen to all the talks. And so there's somebody I wanted to have with us for a very long time, for many reasons, but I just would like you to go back, or at least the one of you of my generation, to medical school, when you learned about the eye, the interaction about the retina with the light, and you were told there were only two classes of cells, the rods and cones, who really were able to detect light and do all the wonderful things that we now follow to this. But it's actually thanks to Professor Foster that a third class of photoreceptor in mammals was discovered. And I'm not going to ask you to tell me what they are, or at least not to Gaia, who is the youngest attending medical student at this conference. But these are the photosensitive retinal ganglion cell. And this has really transformed the field of neuroscience of the circadian and and chronobiology to many levels which I don't have the knowledge or the time to gain to. But this is to say that Professor Foster has contributed to fields which go beyond this area to a cross of medicine and biology and neuroscience. And because of that and many other reasons, he's a fellow of the Royal Society. You might don't know, does everybody know what a fellow of the Royal Society means? Does everybody know who Newton is? Faraday? Well, these are fellow of the Royal Society. So this is the league we are talking about. So it's my great honor to have, well, I'm married to an FRS, so I'm very proud. I think being an FRS is a very important thing because it has had a huge impact on society as a whole. So it's my great pleasure to have here Professor Foster. I also read his book, Time Life, which is a wonderful book, and been to some of his talks before, so I'm sure you will understand why I'm so excited about having him. Professor Foster, we're all yours.
Thank you very much indeed, Marta. It's a great honour to be here. I've learnt so much over the past few days chatting and listening to the presentations. To answer your question, what does FRS stand for? I'm surprised nobody actually shouted out former research scientist, which is, has been suggested. So I want to stress that I work in the area of circadian rhythms and sleep, and this is special pleading because I'm not a psychiatrist, I'm not a psychologist, so I'm going to ask you to be very, very gentle with me. Okay, so my overall aims are to highlight the links between mental health and the sleep and circadian systems, so illustrating how their disruption can promote the development and persistence of poor mental health, and how sleep and circadian systems can represent a new target for therapeutic interventions to reduce the severity of mental illness. Now, I know from the many conversations I've had over the past few days that I'm pushing at an open door, and a rather elegant open door, and I've very much enjoyed listening to all the ranges in which sleep is embedded in your research. So what I thought we could do in the next few minutes, and the great struggle with this talk is what to include and what not to include. I mean, the first version of this presentation was about 200 slides, and after severe whittling down, it's got to about 195. So, okay, so what I thought I'd do is provide a brief introduction to circadian rhythms and sleep, and mention, as Marta was saying, those photoreceptors. Then talk about the nature of sleep and circadian rhythm disruption, what I mean by that, and some of the mechanisms underpinning it. Then the relationship between mental health and sleep and circadian rhythm disruption, SCARD, and some observations in humans. And then perhaps the most important bit for me, which is thinking about a mechanistic framework about how SCARD and mental health might be linked. Then move on to treatments and flag up some of the power of light in depressive illnesses, and then finish with just a few slides of where we're going using light as a new sort of target for drug development. So let's kick off with this brief introduction, and something that is so obvious, I think we often forget about it. We sit on a planet that revolves once every 24 hours, but the consequences are absolutely profound. So during the night, it's dark and it's cold invariably, and during the day, there's UV light exposure, for example, there's lots of light, and it's invariably hot. Now, all life on the planet, and I mean single-celled life, and I mean bacteria as well, have evolved a response to this very dynamic world, and made a decision to be either adapted to be night active or day active, or some portion in between. For us, of course, we have a period of physical inactivity, which we broadly call sleep, and of course physical activity defined by our consciousness. Now, what I hope to impress upon you is that whilst we may be physically inactive during sleep, profoundly important aspects of our biology are going on whilst we sleep. We've compartmentalized our biology into these very important states, and of course they interact. The quality of our sleep will define the quality of our consciousness, and indeed our consciousness will impact upon our sleep. So the first point I'd like to make is the circadian system, this internal biological clock, anticipates the 24-hour light-dark cycle and adjusts or fine-tunes our physiology in advance of the changing conditions. This anticipation is really important because if you know, as it were, that dawn is going to be in 2 or 3 hours, you can start to crank up your metabolic systems, your alertness systems. So when dawn actually arrives, you can get out there and exploit the new environment to the full. So anticipation has provided an immensely important selective advantage. So in response to this 24-hour world, our biology has become extraordinarily dynamic. And what we see in this slide are 6 different examples with a time base of 24 hours of some of the changes that occur in our biology across the 24-hour day. So the first one is melatonin. And melatonin is a very good marker of the biological clock, and it's used all over the place as a phase marker of where the clock is. But it illustrates very nicely that this rhythm in melatonin is peaking before the lights, it is rising before the lights go off, peaking in the middle of the night, and then dropping in anticipation of dawn. Now, I'll just mention here that melatonin is often incorrectly called a sleep hormone. It is most emphatically not. It's a very mild modulator of sleep. It can speed up the time it gets you can get to sleep by 10 minutes or so, maybe 20 in some individuals, and it can speed up the rate at which you can lock onto a new time zone. But it's very variable, and the effects are relatively small. So it really shouldn't be called a sleep hormone. If we look at some of these other changes, growth hormone, which is produced almost exclusively during the first part of the night, and growth hormone's fascinating because if you don't sleep, you actually truncate the release of growth hormone. So it's under circadian control and sleep control. There's a drop in core body temperature, only about 1 degree, but if you block that drop, then getting off to sleep can be somewhat problematic. So that drop in core body temperature can be very important. Cortisol, as many of you will be aware, rises, peaks in the morning, mobilizes glucose, increases blood flow, heart rate, and so in preparation for activity. Testosterone, fascinating, rising in the morning and correlates with increased sperm motility at that time of day. And I have a wonderful story about that, which I'll tell you about over lunch. So ask me about the testosterone story. And of course, multiplication accuracy is remarkable over the 24-hour day. The low point, no great surprise, is in round about 4 or 5 o'clock in the morning. But it's very important to emphasize how impaired we are in the early hours of the morning. A wonderful study by Drew Dawson in Australia showed that the level of impairment in the early hours of the morning is worse than if you consumed sufficient alcohol to make you legally drunk. So if you take nothing from this presentation, if you're driving a car at 5 o'clock in the morning, your ability to drive that car is worse than if you were legally drunk. Okay. And if you want to know more about melatonin and to support my statement about it not being a sleep hormone, I wrote a very brief review for Current Biology, and there's the reference. Okay, so the key point, the circadian system delivers the right stuff in the correct concentration to the appropriate tissues at the right time of day. And without this time structure provided by the circadian system, our biology, including our sleep-wake systems, are plunged into chaos. Now, of course, there's nothing new. I wanted to draw your attention to Robert Burton in his 1621, The Anatomy of Melancholy. I think this is an amazing quote. Our body is like a clock. If one wheel be amiss, all the rest are disordered. The whole fabric suffers. With such admirable art and harmony is a man composed. So it's exactly what I've just said. And this is a photograph of Robert Burton's memorial, who died in 1639, and this is in Christ Church College in Oxford. Okay, so with this time structure in mind, it's no great surprise that if we look at changes in biology across the day, we see lots and lots of dynamic changes. So, for example, I mean, gout, which is sort of, I can't point, but you can see gout up there, often in the early hours of the morning. Osteoarthritis versus rheumatoid arthritis. Osteo is evening, rheumatoid is morning. One very important area is the timing of heart attacks and stroke. So there's about a 50% greater chance of having a stroke between 6 a.m. and 12 noon than any other times of the day. And one can go on and on. I've talked about peak alertness, there's suicides, it's masses of stuff. I don't have time to talk about it, but as Marta said, you could read all about it in this book called Lifetime. And in addition, common drugs and treatments have well-established time-of-day effects. So we talked about blood pressure medications and that peak, that 6 a.m. to 12 noon peak. Well, it's been shown that if you take your antihypertensives before you go to bed, rather than first thing in the morning, when the peak is occurring, then over a 10-year period, you can reduce the chances of death by 50%. So time of day is having a huge effect here. And there's lots of other examples, and I've thrown up a few for psychiatry, where, of course, many of the antipsychotics have a very long half-life. So to some degree, it doesn't matter at what time you take them. That's my understanding, but I'd like to discuss that with you. But they will also have an impact upon weight gain. And so, for example, olanzapine, it's been suggested, avoiding in the evening because it can promote weight gain and glycemic control. And we've got clozapine, for example, high sedation effects, so avoid taking first thing in the morning. So this emphasizes that the body is highly dynamic. And I just also add one point here, is that many experiments, of course, are on mice, quite rightly so. They're a fantastic model, but they're nocturnal. We are diurnal. And horrible mistakes have been made by extrapolating from the findings in a nocturnal mouse to trying to replicate in a human, which is diurnal. So you've got to apply drugs or interventions at the appropriate biological time. So, for example, in psychology, a lot of cognitive testing is on nocturnal rodents, which are woken up during the middle of their sleep phase during the day, and then, of course, the data are extrapolated to us, which is our day phase. So be aware of that. Okay, and again, oh, funny, that should pop up again. This is discussed with references in Lifetime, and actually, I've now remembered why I wanted to show that, not just for sales, but the fact that there are over 900 references in the book. And Penguin allowed me to do this, so most of the statements are justified with a reference. So you can check all this sort of stuff in the references here. Okay, let's think about the organization. We go to the hypothalamus, and the base of the hypothalamus, there's a structure called the suprachiasmatic nuclei. It's a paired structure, only in total about 100,000 cells. There's immense complexity to this structure in the base of the brain, and if it's destroyed, circadian rhythms, 24-hour rhythms are abolished in terms of overt behavior and hormone release. The key point is that if you take one of those neurons and you look at it at a dish, you see that clock genes are turned on, they produce clock proteins, those form a complex which enters the nucleus and inhibits further expression of those genes. The proteins are then degraded in the cytoplasm and then in the nucleus, and so the clock genes can work once again. So what you've got is this negative feedback loop, what's often called a transcriptional translational feedback loop. And I'm going to dip into this in a bit more detail later on, but just to flag up at this point that subtle polymorphisms in those clock genes have been associated with your tendency to adopt a certain chronotype, whether you're a late type, an intermediate dove, or an early lark. Now, that's not the only basis of chronotype. Your age will influence this, your levels of circulating sex steroids, big importance, and also when you see light. So that's something else we might want to talk about later on. So what happens is you get this beautiful oscillation of clock protein production and degradation. But that is of absolutely no use, this internal day, unless the internal day is locked to the external world. And the most important environmental signal that regulates the internal day is exposure to the light-dark cycle, which is detected by photoreceptors within the eye. So the light-dark cycle sets this transcriptional, translational feedback loop. Now, also I want to stress here, you need relatively bright light, especially in the morning, and so a robust signal to set the clock, and I'll talk about light levels briefly later on, is about 10,000 lux for 30 minutes. So this isn't a brief flash of light, it's bright light over an extended sort of period, which is the sort of thing you get outside. Okay. I also wanted to flag up that there are big male and female differences. So in mice and in humans, females tend to be more sensitive, or the clock seems to be more sensitive to light than in males. So for example, in jet lag, women will adapt on the whole faster than men. It's a really quite extraordinary effect in female versus male mice, and that's another story. So the point is that molecular oscillation is then translated into the dynamic changes of physiology that I introduced at the beginning of this presentation. Now that's kind of what we thought was going on until relatively recently. This master clock in the SCN forcing rhythmicity, driving rhythmicity in the peripheral physiological and behavioral systems. And we got that badly wrong. In fact, there seems to be a capability in most cells of the body of producing a circadian molecular oscillation. So there are literally billions and billions of individual clocks which are being regulated by a master clock within the suprachiasmatic nuclei within the brain. So although we often use the shorthand of the body clock, in fact, it's much more accurate to call it a circadian system or indeed a circadian network. Now, I just want to touch on entrainment and pick up a point that Marta introduced, which is, okay, so under a light-dark cycle, we have this beautiful oscillation, and the phase, the timing, occurs at the same point every day. But if you are under dim light, as you might find in an intensive care unit or a nursing home, or, and I'll come back to this later as well, if you've lost your eyes, you don't have that entraining signal. The clock ticks, but it slowly drifts out of sync with the external world. And the question we asked quite some time ago now is, well, how the heck is the SCN, this master clock, entrained by light in the eye? We know it's the eye, because if you have no eyes, you can't entrain. And the other thing that we really wanted to flag up, remember it's relatively bright light, 10,000 lux of 30 minutes. This is a very different light signal than the signals that we use for vision. And to cut 20 years of research short, what we showed is, first of all, in mouse models and actually other rodent models and then humans, is that you can lose all, and we did this in mice with genetic tools, you can lose all your visual cells, the rods and the cones. And what's extraordinary, and I still find these data exciting, is that that rhythm of circadian behavior is still entrained by a light-dark cycle. So you can be visually blind, have no capability of conscious vision, but you are not clock blind. And that led to the discovery of these photosensitive retinal ganglion cells based upon a melanopsin or OPN4 photopigment, which is peaking in the blue part of the spectrum, which is why there's so much endless discussion about blue light, which I'd love to talk about, but we can perhaps do that over lunch. We were able to show this in mice and humans. David Burson showed this in rats, and Dennis Dacey in the macaque. So we had a range of different studies all identifying this extraordinary group of cells. This is what they look like. They form this photosensitive net across the arc of the eye, acting as this sort of, as I say, net capturing light and then firing off this information into the master clock. They also do other things as well. They're a generalized irradiance or brightness detector system, which again is another topic I can cover at another time. Okay, now sleep is more than just the clock, of course. So if we think about it, and this is where we have the beginnings of the overlap between psychiatry and the sorts of physiology I work on, is if you think about consciousness, it's underpinned by many of the neurotransmitters that we've been talking about this week: histamine, dopamine, noradrenaline, serotonin, acetylcholine, glutamate, driven by orexin and the wake-promoting circuitry. If we contrast that with sleep, then of course we've got, broadly speaking, a drop in the release of some of those neurotransmitters, not acetylcholine, which is actually upregulated during REM sleep. And then we've got circuitry in the midbrain flipping from the non-REM to the REM states. And indeed, during REM, we experience this muscular paralysis, ideally from the neck down. The timing of this flip-flop is due to the circadian system, but also perhaps the most intuitive part about the timing of sleep, which is the homeostatic timer. And these two systems interact, and this is a big focus of some of the work that we're doing at the moment. But let me sort of give you a brief summary of how the circadian systems and the homeostatic timer interact. And this is the classic two-process model developed by Serge Dahn from Groningen. So, Iris, did you know Serge? Yeah, amazing man. Sadly died a few years ago. And Alex Borby from Switzerland. So what we have in the beginning, in the morning, we have the homeostatic drive for sleep, and adenosine is a very important biological signal in this case. So adenosine rises during the wake phase and dissipates during the sleep phase. So mid-late afternoon, your sleepiness drive is very high, high levels of adenosine within the brain. You ideally don't fall asleep because of the action of the circadian system, which essentially is producing a drive for wakefulness. So the drive for wakefulness at the beginning of the day is relatively low, and in fact, it rises through the day, keeping up with that sleepiness drive, the homeostatic drive. In fact, the circadian drive for wakefulness is at its highest just before we go to sleep. The clock says, now's a good time to sleep. We sleep. During sleep, the circadian drive is low, and then it kicks in the morning when we wake up. And then during sleep, we have the 4, 5, 6 cycles of REM, non-REM sleep. Just to point it out here that the reason our cup of coffee is so effective at keeping us awake is because it's a pretty broad-spectrum adenosine antagonist with the half-life of 5 to 9 hours. So a cup of coffee really does make you feel more alert because you've blocked the adenosine receptors, which are keeping you, which detect how sleepy you are. Okay, so let's now move to the second topic, which is SCARD, sleep and circadian rhythm disruption. Now, in non-psychiatric conditions, shift work, which is where SCARD has been studied most extensively, extended working hours, reduced sleep, light and noise pollution, which is endemic within individuals of a lower socioeconomic group. And there's a House of Lords report I was involved with talking about the impact of light and noise pollution on human health. We called it the neglected pollutants, and it's an interesting report. Intensive care, disaster, completely mixed signals, and of course stress and illness will all contribute to SCARD. And the processes can be summarized here. So we have psychosocial disruption and internal dysynchrony, which I'll explain in a bit more detail in a moment. But we have essentially two powerful interacting loops. So in terms of internal dysynchrony, massive hormonal disruption of all these key hormones that we've been talking about, and also the gut microbiome, some very nice work emerging in that area. Toxin clearance, so beta amyloid is largely cleared from the cerebral spinal fluid whilst we sleep, and of course memory and cognition, and I'll give you some examples of that. Psychosocial disruption, difficulty coping, leading to low self-esteem, social issues, frustration and anger, increased worry, anxiety and depression. And these two systems interact to produce emotional, cognitive and physiological pathologies. Now, of course, they will in turn feed back and promote SCARD. So yet another feedback loop. And before we talk about some of those impacts, I just want to point out in terms of the major economic costs, it's estimated from the RAND Corporation that SCARD costs the UK 40 billion annually in terms of reduced productivity and increased healthcare needs. Okay, let me explain internal desynchrony in a bit more detail. What I mean by this is this mismatch between that central clock within the brain, the suprachiasmatic nuclei, and the light-dark cycle, but also eating at the wrong time and exercise at the wrong time. These are also important entrainment cues. So you have misaligned Zeitgebers or time givers. But it's worse than just that, because this can then lead to the intertissue desynchrony, where the brain, the liver, the kidneys, the fat metabolism is all misaligned. The analogy would be an orchestra with all the members of the orchestra playing at a slightly different time, producing this sort of cacophony rather than a symphony. But we can go even deeper. So the cells of a particular organ become misaligned with each other, and indeed the individual cellular oscillators, the circadian systems, the clock genes, can also become abnormally phased, and indeed the amplitude can change. What you've got is temporal chaos. So let's look at some of the psychosocial, physiological and behavioral disruption. And these are in individuals who are not, have no diagnosis of mental health problems. So if we look at emotional responses, fluctuations in mood, irritability, anxiety, loss of empathy, frustration, risk-taking, impulsivity, altered salience, stimulant use, sedative use, and that can blend into illegal drug use. Cognitive responses, impaired problem solving, the ability to multitask, attention, concentration, all of the sorts of things we've been talking about this week, but not in the context of sleep disruption, but in the context of mental illness. And of course, chronic SCARD can lead to really profound impacts upon our health, including, I would add, the predisposition for depression and psychosis. This is what you find, for example, in night shift workers. Let's just look at two. Altered salience. This is a lovely study from Sickhold's group. And what he did was have two groups. One group that slept normally, and the other group hadn't slept for 24 hours before they performed these tasks. And he asked them to remember words with a different emotional content. So positive words, joy, happiness, love, that kind of stuff. Food, maybe, alcohol. And then negative words, hate, war, crime, Trump, maybe, and neutral words such as cotton. So if we lump all the words together, then clearly a loss of sleep has impaired the ability to remember the overall number of words. Now let's break it down, and this is a lovely experiment, into their emotional content. Neutral words, there was a tendency, but it wasn't significant to remember fewer neutral words. A tendency, but not significant, to remember fewer negative words, but there was a massive loss in the remembrance of words with a positive content. You know, basically emphasizing the fact that the tired brain has a greater predisposition to remember negative words, and this has been done in other experiments. It tends to remember negative experiences rather than positive ones. So altered salience. And the other experiment I only have time to talk about, this is another beautiful study from Germany. And what Jan Born did was develop a very difficult problem-solving task, really tough. And so he introduced in the first group that you see here, the task in the morning, so that people became familiar with the task. And then they were asked to perform the task in the afternoon. And you see that 20% of the group 20% of the individuals solved the problem, so relatively small success. The next group introduced the task in the morning, they performed it the next afternoon, but they weren't allowed to sleep. Interestingly, they were no different from the morning group. Of course, the fascinating group is introduced the task in the morning, became familiar with it, performed it the following afternoon, but allowed to sleep normally, and the problem solving went up hugely. So sleep promotes the ability to come up with novel solutions to complex problems. I think a really lovely set of data, as I say, Jan Born's work in Germany. Okay, let's now move on to mental health and SCARD and some observations in humans. So the majority of individuals, and depending on the papers you read, but it's invariably greater than 80%, with a diagnosis of a mental health problem have some sort of clinically significant level of SCARD. But the key point is that there are multiple phenotypes. It's not just one, as illustrated here. So we see in the top box essentially a fairly stable pattern of sleep, and so the black lines represent sleep, and you see that this is a healthy individual going to bed a little bit later at the weekends, but broadly speaking, stable. Then there's a condition called advanced sleep phase syndrome, which you tend to find in aged adults as well. And then we go into the sort of SCARD phenotypes which you encounter in mental health conditions. So delayed sleep, very common in depression, psychosis and mood disorders. This is perhaps the most common of the sleep phenotypes. Then free running, again depression, psychosis, mood disorders, and I'll show you an example of this in a moment. Classical insomnia, when you're not getting to bed at the time you want, waking up, and then frequent sleeps during the middle of the day. And then in severe mental health conditions, you've got massively fragmented, no obvious 24-hour pattern at all. Now, Kraepelin, and we've already seen several images of Kraepelin so far, noted in his textbook that abnormal sleep patterns and mental illness seem to be linked. But since the 1970s, and I'm sure none of you here are responsible for this, SCARD in psychosis, schizophrenia, was viewed by some as merely the byproduct of antipsychotic medication, even though Kraepelin was talking about this almost 100 years before antipsychotics came into use. Now, I don't want to say that antipsychotics are not influencing sleep-wake, but they're not the driver, and I'll come back to that point in a moment. And the reason I got into this was because it's also been thought that SCARD, such as in psychosis, is dismissed because of a lack of work or structure within the environment. And this is a quote from a senior London psychiatrist, I would stress, not at the Maudsley, who said to me, "My patients can't hold down a job, so no wonder they get up late, miss my clinic, and don't have friends." And I thought that was actually rather a foolish thing to have said. So it prompted me to start working on patients with a diagnosis of schizophrenia with Eileen Joyce. Now, let's have a look. So what you can do is you can use standard questionnaires, wrist actigraphy, to monitor sleep-wake profiles in patients with a diagnosis of schizophrenia. And as I say, these were Eileen Joyce's patients, and the work was undertaken primarily by a postdoc in the lab called Katharina Wolf. So this is the sort of pattern you get. Note, this is on a 48-hour time base, and that's done because you can see the patterns more clearly. And the line, the black line, represents midnight. This is actually an unemployed individual, so they're going to bed a little after midnight, and their wake is a bit ragged, but it's pretty stable. We can also ask individuals to collect urine, and from that deduce the peak of melatonin. You see a nice rest activity profile and a nice clear phase of melatonin as you go through consecutive days. From the top to the bottom, that's going later in time. So here's our unemployed individual again, and we compared unemployed, employed, and individuals with a diagnosis of schizophrenia. And these are the patterns we saw, and I still find this extraordinary. Patient 1 was perhaps the most stable, but you'll see lots of activity after midnight and a delayed melatonin profile. Schizophrenia 2, I'll come back to in a moment, she was drifting through time, apparently normal visual system, so we don't understand what the basis of that was. And then we see some people sort of kind of drifting and then falling apart all the way through to schizophrenia 7, where there's no obvious 24-hour patterns at all. These rhythms are completely smashed. And you get a corresponding change, in many cases, in the melatonin profile. Okay, so one first thought is, are these different phenotypes useful for condition or treatment stratification? And that's something we will come back to. This is just a long-term record over 4 years of patient 2. and you see that it was extraordinary. She was drifting through time almost endlessly, and in year 4, she was just not adapted at all to the external world, and her symptoms of psychosis were much worse. Light exposure in this group was very interesting. You see that domestic lighting is around about 100 lux or so, maybe up to 400. We're about, I guess, 200, 150 lux in here now. But outside, it's closer to 100,000 lux. And I urge you to download a lux meter onto your smartphone, because then you can actually become a complete light bore. Say, oh my God, how dim is it in here? But it's fascinating to look in wards and different settings like nursing homes. Okay, so this is a comparison of the schizophrenia and unemployed individual, and what you see, no great surprise, is about a 60% less light exposure in schizophrenia patients. Why is that important? Well, because you've got a very weak, abnormal light entrainment signal. So no wonder some of them were drifting through time. There's not a brighter light exposure. This is some EEG, an unemployed individual. You can see the classic sort of quiet rest, awake, going through the stages 1, 2, 3, 4, into deep sleep, the green at the bottom there, bouncing up to REM sleep, and then going through several cycles. This is a nice illustration also showing that most of the deep sleep occurs during the first half of the sleep episode, and most of the REM sleep on the second. That's also under circadian control. What we saw in schizophrenia was a much more fragmented pattern of REM sleep and no stage 4 deep sleep at all. And of course, REM sleep has been associated with the processing of emotions, and deep sleep with memory consolidation and information processing. Okay, so a summary is we've got poor subjective sleep, fragmented sleep, a whole mass of problems that I've gone on about. Now, there was no obvious correlation with the antipsychotics these individuals were on, but the sample size is too small and the antipsychotic administration too variable. I think this is a really very interesting study for the future. Can we correlate different sorts of sleep phenotypes with antipsychotic use? We certainly can say that SCARD is not driven by a lack of structured work, because the unemployed individuals were basically the same as the employed. But this bit down here, impaired cognition and memory, increased substance abuse, metabolic abnormalities, cardiovascular disease, reduced immunity. Is this due to the psychosis, which has been the assumption, I think, in many cases, or is this the product of SCARD? Bipolar, this is a lovely study with Guy Goodwin in Oxford, and we used his mood disorder questionnaire, and some of you will be familiar with this, but basically you can identify individuals at risk versus high risk of developing bipolar. They haven't a diagnosis of bipolar. This is a way of indicating vulnerability. And so we had participants with a low score, healthy controls, a high score at high risk of developing bipolar, and then bipolar syndromal individuals. So let me show you the rest activity profile of a low-risk individual. We get a beautiful profile, very stable rest activity cycles, about 40 in this group. But look at the high risk. They didn't have a diagnosis of bipolar, but they were already showing a breakdown of their sleep-wake profile. And if we then quantify that by looking at the stability of sleep during the 5 hours of the most consolidated sleep, we get our low-risk population, a significant disruption in the high risk, but no diagnosis of bipolar, and then, of course, the syndrome where you have disruption. So again, sleep phenotype, a possible trait marker for mood disturbance. Let's look at now this mechanistic framework. Oh, gosh. So let me whiz up. So the traditional view of how mental illness and SCARD are linked is essentially it's the mental illness simply driving the SCARD. And I think based upon observations in humans and really an increased understanding of the mechanisms of sleep and circadian rhythms, we provided a different sort of conceptual model. And that is that SCARD and mental illness share common and overlapping pathways in brain circuits. And what I mean by that is that if there's a change in a neurotransmitter, let's say dopamine or serotonin, that predisposes you to a mental health state, it's going to almost definitely have an impact of SCARD at some level. Remember, all of those key neurotransmitters are involved in sleep-wake regulation. Now, so you have that core framework of vulnerability at the beginning. But of course, SCARD produces short and long-term emotional, cognitive, and physiological problems, which can exacerbate the mental health. And of course, the mental health, via psychosocial, physiological stress, and possibly medication, can exacerbate the SCARD. And so what you get is this positive feedback loop. So you go from a position of vulnerability, and you can move very rapidly to a pathological state. So what evidence do we have for this? Now, this is going back to the molecular clockwork I talked about earlier. And so these are some of the important circadian clock genes, the PERS, the period, and the cries. They're turned on by a complex involving BMAL and clock, leading to transcription, translation, the proteins entering the nucleus, inhibiting that transcriptional drive. Then, of course, you lose the transcriptional drive. The proteins are then degraded in the cytoplasm and the nucleus, and the whole thing kicks off again. And you've got this wonderful negative feedback loop generating a 24-hour oscillation. Now, what's turned out to be fascinating is that polymorphisms in many of these, oh yes, and then there's an output, which is really important. And then polymorphisms of some of these key genes have been associated with psychiatric issues. So BMAL, psychosis, severe depressive disorders, clock, sleep disruption, mood swings, reward-seeking behaviors, PERS, implicated in seasonal affective disorder, major depression. The cryptochromes, again, specific mutations, are strongly associated with anxiety and delayed sleep phase disorder. If we look at the synaptic outputs, then so many of the pathways we've been talking about over the past 2 weeks, the serotonin pathway, the GABAergic pathway, most SCN neurons are GABAergic, incidentally, and of course the whole mass of dopamine and dopamine-associated genes, again linked to sleep and circadian rhythm disruption. One we studied has been SNAP25. And in view of the time, I'm going to go over the SNAP25 study fairly quickly. So, as many of you will be aware, that SNAP25 has been associated with psychosis risk in humans, and particularly certain risk variants. So what it does, of course, is allow a presynaptic vesicle to fuse with the presynaptic membrane and discharge neurotransmitter into the presynaptic cleft. Now, we used a model of this in mice, and I think it's important to make clear my position here, which is current animal models of schizophrenia or psychosis are not intended to serve as the animal equivalent of the human disorder. Rather, they're designed to test specific causative or mechanistic hypotheses of the disorder. That's, I think, really important. You don't have a schizophrenic mouse. So we decided to... This is a mouse, as I say, that's been used as a model to understand aspects of human psychosis. And so we decided to look at what the circadian phenotype would be in these mice. So they have deficient pre-pulse inhibition. I won't go into that. But the circadian behavior is really fascinating. So here's the wild type, and we get a beautiful rest activity profile. Remember, they're nocturnal, so the blue here is where the light is. This is what you see in the blind drunk or the animal with a defect in SNAP25. Complete breakdown of, well, not complete, but very big breakdown in the circadian behavior. And it depends upon the light intensity. This is under a bright light intensity, and you see that under a dim light intensity, the whole thing gets much worse. Now, I'm cutting I wanted to really spend a bit of time on this because I find this absolutely fascinating. There's an awful lot of individual variation. So if we look at the boxes outlined with blue, these are the wild-type mice, and they show a nice, robust, consolidated sleep-wake profile. But you'll notice that in the blind drunk, the SNAP25 mutants, you can get pretty good circadian rest activity profiles, which then bleed into really appalling sleep-wake profiles. Now, why I find that fascinating is that it does resemble what we saw in human schizophrenia. Now, I think there's some interesting implications here. As shown, considerable inter-individual variation of rest activity cycles occurs in patients with schizophrenia. And this variability would normally be ascribed to the genetic variability typical of any human population. But what we're finding in the SNAP25 mouse is huge variation in the circadian phenotype of genetically homogeneous mice within a highly similar environment. And I was really surprised by that. So what does it mean? Does it mean that a single predisposing genetic trait can produce considerable heterogeneity alone, or that heterogeneity can arise from very subtle environmental factors? And I think that's something that needs to be explored further. At what level is the mutation having its impact? Well, I will again cut to the summary slide here, which is that the light input is fine, the clock is fine, but it's the outputs from the clock that are defective. So we get abnormal phasing of output rhythms such as cortisol and, of course, the behavioral phenotypes that I showed you. And in a sense, the defect seems to arise from abnormal neurotransmitter release between clock neurons and SCN output neurons. But why I find this fascinating is that defects in SNAP25 and synaptic signaling represent a common mechanistic problem or issue in the generation of SCARD and psychosis. So it reinforces that model. So we've got loads of evidence for that, and let's now focus on this, which is the SCARD itself. So if the SCARD is exacerbating the mental illness and the mental illness exacerbating the SCARD, what happens if we address the levels of SCARD? So could we think of SCARD as a new therapeutic target in mental illness? And this is work we did with Dan Freeman, which is a proof of concept, studying a large number of participants using Colin Espy's Sleepio, which is a digital cognitive behavioral therapy for insomnia. And to cut to the chase, this is paranoia, also hallucinatory experiences, and those individuals showing an improvement in their sleep. Here's the controls, no change before and after, but with a sleep intervention, this is the level of paranoia before, and this was after an intervention, which is amazing. So, and a highly statistical result. So simply by consolidating sleep alone and a partial consolidation, you can reduce paranoia, which is what's illustrated here, but also hallucinatory experiences. Okay, so let's now think about treatments. And first of all, I'd like to touch on seasonal affective disorder, which, as many of you will be aware, is individuals experiencing depressive episodes at a particular time of year, often in the winter, but not always. Depression is not obviously correlated with some seasonal event like annual employment, for example, or something like that. And the symptoms are profound depression, sadness, anxiety, weight gain, irritability, and all the rest of it. And it's correlated with day length. So in the United States, we go from Florida to northern United States into Canada, spanning a big light exposure from 10.5 hours to 6 to 7 hours on its shortest day. And what you see is that SAD increases to about 10% as you go north. Winter blues also show a corresponding increase. Now, the top here is at 50 degrees north. The studies in the UK, which start at 50 degrees north, also show a trend. But remember, in the USA, at 50 degrees north, we've already got 10% showing SAD, whereas we don't peak even at 69 degrees north, up to 10%. So the trend is the same, but the specifics are different. And it's, again, not clear why. Maybe it's simply underreporting. The really important point is that for SAD, you can treat it with supplementary light. And there's lots of different sorts of light boxes. The one thing I would say is that this device here ramps up, mimics to some extent the dawn sunrise. So it's an increase in intensity over time. And that seems to be the most effective treatment. In an early study comparing morning light, evening light, and placebo, we see the placebo effect, the evening light, which is not different from placebo, and then the morning light, which is highly significant. So you've got about a 60% response after 4 weeks of morning light for reducing the levels of SAD. How does light work on SAD? Well, the original assumption was it was melatonin suppression. So under normal circumstances, the day length is encoded by the central nervous system and communicated via the sympathetic nervous system to the pineal, and you get a profile of melatonin which mirrors the night length. If we expand the night length, winter night lengths, then you get an expanded melatonin profile. And it was thought that that is the SAD signal. It is not. So by changing melatonin levels, and so changing from an autumn profile to a spring profile, or vice versa, it has no effect on the SAD at all. So it's not mediated by melatonin, which was the expectation. Circadian stabilization. So the idea is, and this is the most favored view, that individuals with SAD have a long chronotype. This prevents them satisfactorily entraining to a weak light-dark cycle, and so you get internal desynchrony and the system falls apart. Supplementary light hits the clock, consolidates the sleep-wake cycle, and you reduce some of the symptoms of depression. There's also a thought that light acts as a serotonin-selective reuptake inhibitor, an SSRI. The evidence for that is interesting but not strong. Okay, so non-seasonal depression, very similar profile. Here's the placebo over 8 weeks and a drop in depression, in non-seasonal depression. Fluoxetine is only significant after 8 weeks compared to placebo, but light, 10,000 lux for 30 minutes, is highly significant after week 2 and highly significant above fluoxetine at week 8. Fascinating, if you combine light and fluoxetine, it seems as though the two are additive. What the hell is going on there? Don't know. It's either both acting in the same way, or they're interacting on different pathways. And light and bipolar, again, similar sorts of treatments, 7,000 lux for 60 minutes versus red light placebo, and we see that bipolar remission much greater with a light treatment after 5 to 6 weeks. Okay, mechanism, we don't know. So the bottom line, before I just show a last few slides, is SCARD is associated with a range of mental health disorders, and effective interventions that target SCARD can lead to improvements in psychosis, mood disorders, depression, and anxiety. And I think understanding the mechanisms gives us the potential for biomarkers for early detection. We can monitor onset, progression, and relapse. We might be able to use the phenotypes for condition treatment stratification. And we've got some fascinating data, which I don't have time to, I told you how many slides I took out, which is that the circadian architecture of individuals who are resistant to lithium seems to be different for those individuals who respond to lithium. That's fascinating. More work needs to be done. But then new targets for intervention. So just to finish off, I want to tell you where we're going with all of this and what can we do in addition to light and cognitive behavioral therapy, and where we're focusing our efforts is to fool the circadian system with drugs that mimic the effects of light on the clock. Declaration of interest. This is partly funded as a result of our spin-out, Circadian Therapeutics, and I work very closely with Arti and Shri in this enterprise. Okay, so what we want to do conceptually is, just like we've just seen, you expose those photosensitive retinal ganglion cells to light, you trigger a light signaling pathway, which then results in an entrained rhythm to the light-dark cycle and a stable entrainment of phase. The aim is to replace light with a drug that triggers the same signaling pathway to produce entrainment and stable entrainment. So that's the theory. Let me show you the data in mice, first with the cartoon and then with the real data. So we've got a mouse here in a running wheel. It's running when it thinks it's night. Its body clock is slightly shorter than 24 hours, so it's getting up a bit earlier and earlier each day. This is in darkness. We then introduce the drug, and this gives you really a visual representation of the data, which I'm going to show you in a minute, so you know what you're looking for. It entrains to the drug, take the drug away, and it drifts off again. So these are the real data. The control drifts off, no effect of the daily injections. Here's a weak dose, and there's a hint of something going wrong, but at 20 milligrams per kilogram, you get beautiful entrainment. It's just like light. Okay, where we are? Well, we've shown all the preclinical efficacy on the mouse work. We've tested that it's tolerated very well in humans, so there's no safety concerns, and we have just got a funding from the UK Biomedical Catalyst to generate the 4 million for the first in clinical trials. The first group will be individuals, as I touched on right at the beginning, who've got no eyes. So this is an individual who's normally sighted, and this is a collaboration with Blind Veterans UK, and you see that the melatonin profile occurs at the same time week after week. This is an individual who's lost their eyes, and you see that their melatonin profile is drifting through time. They're time blind, and this is some quotes from these individuals. I feel like constant jet lag. It feels like constant jet lag. I feel ill all the time. I'm at my wit's end, suffering from variable bedtimes and wake times. I'm slowly becoming socially isolated. And these individuals are in a dreadful state. And they say, I can kind of adapt to not being able to see. What I can't adapt to is my body fooling me about what time of day it is. So they will be the first group to get the drug, because that'll be a proof of principle. But I think short-term use in other conditions, such as mental illness, in the aged adults, in dementia, neurodevelopmental conditions, and neurodegenerative diseases, could be really powerful. Stabilize the sleep-wake profile, wean them onto light exposure, exercise, and eating at the same time every day. Classic cognitive behavioral therapy for insomnia. And so we could kickstart, I think, with this drug, CT-1500, a stable sleep-wake timing and hopeful a reduction in symptomology. Okay, sorry, I've overrun. That's what to include, I don't know. I hope to give you some sort of introduction to circadian rhythms and sleep, talk about sort of biological timing and general health and the impact of SCARD, then talk about the relationship between mental health and SCARD and some observations, particularly in schizophrenia in humans. Then that mechanistic framework and, you know, the overlap of pathways, and that positive feedback loop that can make the condition much worse, and that by breaking that feedback loop, you can reduce symptomology. Light treatments could be one option, and then I think on the horizon, we've got some potentially exciting drugs which are mimicking the effects of light on the clock. So thank you for your attention.
I'm going to say that we eat enough at this conference, so we can have 5 minutes certainly for questions.
I apologize.
No, please don't. So while you warm up, it's interesting what you were saying about that direction between mental illness and SCARD, because sometimes when the people I see in my clinic who have by definition psychosis, when I ask them, if you have to tell me what would you like me to help you with as your first priority, is sleep.
Yeah, that's what
It's not hallucination. Yeah. It's actually sleep.
Yeah.
And they have a sense that if we can reset their sleep, some of the symptoms or some of the practical difficulties like not getting a job
Yep,
would
social
actually
isolation, exactly.
sort of improve. But the majority of the people I see live in a very polluted environment where you can put noise, light, and everything else we mentioned. And often cannabis is the way they try to reset their sleep.
Or indeed alcohol from
Yes.
some, yeah.
Yeah, so the one I see are cannabis connoisseurs, but that's one of the most common reasons why they would transition to a daily use, because they try daily to reset it.
Sorry, I've got a lot of questions, so just as I was first I'm an all-day psychiatrist, so the issue about lighting care homes, maybe I'll ask you at lunchtime, but that could be really quite game-changing, I would think, in the care homes. And
well, there's some even data on that. I mean, there's a Dutch group who increased the amount of light in the day areas and had darkness in the sleeping areas, and transformed a really ragged sleep-wake profile into a much more robust one. And critically, it reduced the levels of cognitive impairment.
And challenging behavior?
So they looked at cognitive impairment, but they didn't look at anything else in that study. Yeah.
Okay. And I guess ADHD and sleep?
Absolutely a disaster, as you will be aware. And so many parents are resorting to melatonin as a last resort, and invariably it doesn't work long term, and so we don't have anything. I think, I think those drugs that we're working on may be really powerful for that. That's the hope.
Okay. Last thing, menopause?
That's a whole other lecture. No, I think, and we touched on this earlier. So we do know that estrogen and progesterone are interacting with receptors in the master clock and the outputs from the clock. And we clearly know that sleep-wake behavior is changing in individuals in perimenopause and menopause. What's fascinating is that the changing levels of estrogen and progesterone across the menstrual cycle have essentially precluded women for circadian studies because they alter the phasing of the rest activity cycle. Then women tend to be much less precise because of these changing hormonal rhythms. So we don't know, either in female mice or humans, what's going on. And we put a big grant into the Medical Research Council to study this, because we know that there are lots of estrogen receptors in the dorsal part of the SC net, and we wanted to tease apart all these things. Didn't get it, but we'll keep on trying.
Thank you.
Thank you. I'm just wondering if there's much evidence around modafinil, either with the circadian rhythm disorders or for those persons with serious mental illness and trying to normalize sleep.
Yeah, I think what modafinil is doing is acting on the sleep circuitry rather than the circadian circuitry. And so you can mask some sleep-wake problems by essentially inducing sleep and activity. And of course, modafinil has been was used in the United States for shift workers. But what it's actually doing in terms of the sleep and circadian architecture isn't really clear. I mean, of course, it was used, it's much better than amphetamines. Coming down off amphetamines, you don't have a friendly fire that was reported in the Gulf War. So it's been used by the military, to try and keep people awake. But precisely what's going on, it's unclear. I think it would be really very interesting in the same way that, intensive care and intensive care syndrome, where long-term deep anesthesia, what seems to be happening there is that as people are taken off the deep anesthesia, they sort of wake up, as it were, and then dream. It's actually the anesthesia seems to be suppressing some of the important things going on during sleep. So whether modafinil is doing the opposite, and we're seeing, because we're losing sleep, what's going on with cognition, memory retention, simply don't know. It's a really important question.
I actually was going to ask about the light treatment, and I was thinking about psychiatric inpatient units, and thinking, do you think there would be an opportunity when people are admitted to a psychiatric hospital to sort of in some way try the treatment with them, because you know it can be they can be engaged in it, and maybe they can, because I had a couple of patients and went and bought first of all I wasn't very clear which one they should buy anyway. They bought it, but they were using it randomly.
Yeah, well,
so
this is the problem. And that's why I think if we could use CT1500 to stabilise, let's say over a few months, and then take them off the drug, and then they use that, I think would be the way to do it. Because you've got to stabilise the whole circadian architecture so that you're hitting the clock at the right time to get the effects that you need. And what I didn't have time to go into is that morning and dusk light do different things. So morning light advances the clock, makes you get up earlier and go to bed earlier. Dusk light delays the clock. And we did an experiment, or study rather, on university students all over the world, and correlated beautifully that the later the chronotype, the less morning light they got, which would advance the clock, and the more afternoon, early evening light they got, which would delay the clock. So, yeah, you're absolutely right. I think light is a potential intervention, but it's got to be at the right time. Yeah.
Is there any, have you got any views on the allegations of COVID-related sleep disruption or vaccine-related?
So the data that I'm aware of, so during COVID, people reported worse sleep. And the argument, I think, that wasn't carefully controlled is that because people were not commuting to work, because they actually had an opportunity to have greater periods of sleep, then sleep became decompressed, it expanded, and it then became a much more bimodal pattern, which is probably the default state of human sleep. It's not a single 8-hour period. It's you go to sleep, you then wake up, then you go back to sleep again. And what was happening is that people were defaulting, because they had longer periods to sleep, to a bimodal pattern. They were waking up thinking, oh crap, you know, I've got so much ghastliness going on, getting stressed, and didn't get back to sleep. So I think that was part of the issue. And of course, people with COVID were sleeping excessively. But that, I think we need to tease apart from fatigue, because so many times illness is associated with extended a period of fatigue, which is different from sleep. So sleepiness can be cured by sleep. Fatigue often isn't. And so it's important to disentangle sleep from fatigue. So that's the area that I would know about, yeah.
The drug that is here is under investigation is an adenosine antagonist.
Yeah.
And how does it work?
Yeah, so I didn't go into that. That's a lecture in of itself. We've been teasing apart the light input pathway, and we've shown that adenosine, in fact, this is part of the way the sleep systems and the circadian systems talk to each other. Adenosine inhibits the effects of light on the clock, which is interesting because if you've been awake a long time, you're going to make the clock less sensitive to sleep. So we then used antagonists, and in a sense, it's like a reversed agonist. Take away that inhibitory drive, and you actually excite that pathway. Now, the key thing is, well, why is this drug different from caffeine, for example? And that's because its duration of activity is 2 hours. So it goes in, hits the clock, and mimics the effects of light on the clock, and then stops working. Caffeine has been tried, but of course it's hitting the clock at lots of phases, and then it simply doesn't work. So that's the reason the drug works.
Sono saliti tutti? Sì, c'era pochissimo. Oh, c'era poca gente. Ok. Okay, I think I can start just to present. So welcome back to you, and it's time to present Professor Diego Quattrone. It's a very pleasure for me to present him. He's a professor of psychiatry here in Palermo and senior lecturer at King's College. And he has been leading the clinic for the unit for psychiatric intensive care in London. And his talk is about his experience, corroborated also by his research career, which was mainly on psychosis, transdiagnostic approach, and symptoms dimensions in psychosis. So we met 10 years ago, and we have been working together as colleagues and friends. So it's a very good pleasure for me to introduce him. Diego.
Thank you, Laura. And as you can see now, it has been a very fruitful collaboration since now I'm based in Palermo. So thank you very much for your kind introduction. And thank you all of you for listening to me today. So we are talking about psychiatric intensive care and trying to answering a question. Our main aim is to reduce the use of restrictive practice in psychiatry. We have been aiming for that since ever, but how can we do that? And so we'll try to answer the question if reducing the environmental load actually before going to PQ might be an effective intervention. And we start to talk about Camberwell. Why Camberwell? Because Camberwell has been the place where I lived for many years, and is the place where the Moseley Hospital is based. And so this is a Camberwell tale, basically. Here there are 3 sentences that were raised by my PQ team during the time that I've run the unit. PQ need is not explained by diagnosis. This is in line with what we discussed about the use of transdiagnostic approaches. PQ is the end of an upstream chain, including place, exposure, symptoms, substances, services, and trust. And PQ is the response to an ecological problem, is not the starting assumption. I don't know how many of you have visited the Moseley Hospital, or worked at the Moseley Hospital, but the Moseley is in Camberwell, and Camberwell is quite popular for 2 things in psychiatry. Guess what? It's the capital of the cannabis, exactly. It's known as the capital of cannabis. And have you ever seen a Camberwell carrot? So this is a Camberwell carrot. Of course, the Camberwell carrot does not exist in reality, but it is. This is from a movie, actually a British black comedy with Neil and I. They say, the joint I'm about to roll requires a craftsman and can utilize up to 12 skins. It is called a Camberwell carrot. And they say it's impossible to use 12 peppers on one joint. It's impossible actually to make a Camberwell carrot with anything less. And if you go through London, sometimes we joke on the smell of cannabis, because as long as you walk down to Camberwell, the smell of cannabis increases. What else we know about Camberwell? Just some fun fact. Camberwell has its own butterfly. There is an autochthon butterfly that was discovered on Camberwell. It's called Camberwell Beauty. In 110 and onwards, there has been an industrial change in Camberwell, in particular because there was a canal that was brought to Camberwell. And this led to development of industry, which helped a lot with employment. But unfortunately, after the Second World War, there was a time of deprivation in Camberwell, which started with unemployment and other social facts. But I like also to remind something that was quite innovative in the Camberwell area, which was the Peckham experiment, which was actually the first experiment in terms of medicine, of combining together social life, activity, nutrition, and community. Then in the 50s, it starts migration to the Camberwell area, particularly from the Caribbean area, the Windrush generation. And this was followed in the 70s by, again, another time of social deprivation in Camberwell. And in the 90s, there was a second migration from African people. And then there was the spreading of high-potency cannabis, especially in this part of London. And so we start from the Camberwell beauty to go to the Camberwell beauty butterfly effect. In terms of just a metaphor, just to say that there has been gradual changes in the social context that changed the ecology of Camberwell. And in this context, with Professor Robin Murray, we started a study of exploring how and if and how this had an impact on the development of psychosis. Camberwell is the perfect setting for doing that, because it's not known only as the capital of cannabis, it's known also, unfortunately also as the capital of psychosis, because it's one of the places worldwide with the highest incidence of psychosis. So this study is based, is a continuation of collecting first contact treated incidents of schizophrenia, and it is a bit unique. I don't think there are other studies of this quality because of the use of consistent diagnosis of schizophrenia using operationalized criteria through the OPCRIT. So I don't know how many of you know the OPCRIT. Probably no one, except some people that have worked at the mostly of the IOP. And the reason why you don't know the OPCRIT is that it is a system that is obsolete now, but it is a very useful system that allows us actually to conduct this study with the highest possible methodological quality. The OPCRIT is a list of 90 items. 60 of them are psychopathology, and based on these 90 items, especially the psychopathology ones, you can generate, actually the algorithm generates diagnoses that are operationalized diagnoses. Why this is important? Because of course the concept of schizophrenia in the 60s and in the 70s, when this study started, probably was different from the concept of schizophrenia nowadays. Because of course we know that in psychiatry there are diagnostic trends that change over time. But it's also, at the end of the day, also the clinician that can make a diagnosis of schizophrenia differently from another clinician, because everyone of course has his own way to assess the psychopathology. So the OPCRIT basically allowed us to make diagnosis of schizophrenia nowadays exactly as it was done in the 60s. And we opted for the RDC criteria. RDC are research domain criteria, so these are not RDoC, are criteria that were developed in the 60s, 70s, from the work of Spitzer and the development of DSM-30. Why we choose RDC criteria? Because we wanted, of course, to put our work in continuity with what was done before us. But Robin mentioned in Giovanni's talk why we talk about exogenous and endogenous psychosis. And I think I just added this slide following this question. I think this is a very important point. So actually the OPCRIT has an update that was done a few years ago, And since we are at the Moseley Hospital, I'm pleased to say that actually this software is on the Moseley website, even if it was never used. We basically expanded the original OpCrit using DSM-5 criteria and ICD-11 criteria, and also using a new framework, which is making a diagnosis based on also using an etiological approaches for psychosis. What does it mean? That on top of having diagnosis according to the traditional diagnostic system, we implemented also a way for having an etiological diagnosis. Because at the end of the day, the OpCrit has many items, has not only psychopathology items, has also items that are a reflection of use of cannabis or other aspect of psychopathology that were not used in the original algorithm. What else we can do with the OpCrit? Of course, we can generate symptom dimensions, so having a symptom expression profile for each patient. And this is the first model we developed on the OpCrit in a sample of first episode patients, where we generate a general psychosis factor for psychosis and 5 specific dimensions of depression, manic, disorganization, negative, and positive symptoms. This is a model that worked very well in the UGI project, and it was also used in other first episode psychosis sample. So actually in the development of the OpCrit that we have done, it is even possible to use a reference database with the load of these items, so that each researcher can put in the software his own score, and this is weighted by the reference database of more than 3,000 OpCrit, in a very similar way of the way we generate polygenic risk score, basically. Okay, why is important this for our talk and on PQ? Because, of course, once we generate symptom dimensions, we can correlate the symptom dimension scores with biological and environmental factor. Here you can see the relationship between positive symptoms and cannabis use. This is the UGI study, and here we could observe how the more people use cannabis at first stage of psychosis, the higher was the level of positive symptoms. What happened then in the Camberwell study that you will see in a while? We found exactly the same pattern, or a very similar pattern, with daily users of cannabis having more positive symptoms compared with people who never use cannabis. The second important part of this study, the Camberwell study, was, as any epidemiological study, we wanted to be sure to catch exactly the same area as before. So in the 1965, Camberwell was an entire borough that you can see here, whereas nowadays Camberwell is just a few districts within the borough of Southwark. So we had to recreate exactly the same geographic area in a way that not only we had the same way to do diagnosis of schizophrenia using an operationalized system, but also we were sure to use exactly the same catchment area as before. And then we considered what happened throughout the years. These are 50 years or even more of study. During this time in Camberwell in the 70s, there was the draining of this Grand Surrey Canal. So this light industry that we mentioned before collapsed, bringing lots of unemployment. Then we had migration, as we mentioned, cannabis spreading, another wave of migration from Africa. In the 90s, the rise in street cannabis dealing and police stop and search. And then in 2010, and after that, the dominance of a potency skunk in the street of Camberwell. Moreover, there were an increase in the social inequalities with the central part of Camberwell Green, characterized by high deprivation, Brunswick part being a transitional part of the area, and South Camberwell that actually was characterized by higher income and lower deprivation. So there was basically an increase in the social disparities within the same context. Okay, now it's time to see the results. As you can see, in the 1965, the incidence of schizophrenia was about 12 new cases every 100,000 population, and this remained stable for the 15, 20 years. But then, at the time where we mentioned the Surrey Canal was drained and there was the socio-economic deprivation, we start to see an increase in the incidence of schizophrenia. A second increase is collocated when migration started to happen, and then when cannabis spread in Camberwell, we had another increase. So, in relative terms, in 2021, which was when we finished to collect our data with OPCRIT, and so we have schizophrenia diagnosis made by OPCRIT, the incidence was about 3 times of the original incidence in 1965. And this is a dramatic increase, of course. How could we explain this increase? Of course, genetics of people does not change so rapidly, and even if we consider migration, there is no specific ethnic group that is genetically more prone to psychosis as far as we know, and it would be impossible to assess that anyway. So it's very unlikely that this increase is due to biological factors. In an analysis that I ran in the UK Biobank, I actually looked if the polygenic risk score for schizophrenia changed over time. So people had a diagnosis of schizophrenia in the 80s had the same polygenic risk score of people having a diagnosis of schizophrenia more recently. And the results actually went to the other direction. So it looks like the polygenic risk score for schizophrenia slightly decreased over time, which makes sense if we think that environmental factors risks actually increase. What else is important that happened is the deprivation index, which decreased in 2000, but remained quite high in terms of this area of London compared to other areas of London remains highly deprived. And final factor to consider, the cannabis prevalence in the schizophrenia sample. So if you can see in the 1965, only a few people were using the cannabis in the schizophrenia sample, either because people did not ask or because cannabis more likely was less common. But then, when people with schizophrenia start to use cannabis more frequently, at least in terms of prevalence, we also observe in the blue line the increase of the incidence. So basically, the yellow line almost mirrors the blue line, meaning that as long as cannabis use was more common in a schizophrenia sample, the incidence of schizophrenia was also higher in the population. Another factor that changed over the years in Camberwell is related to violence and aggression. This is the violence, or let's say crime index across the years, and you can see that this has increased quite a lot for different variety of crimes and violence. So now all these factors are very important because we cannot consider one factor independently from the other. And so we started to use a syndemic approach in a way that when we talk about psychosis, cannabis, and violence, these actually three factors are strictly intercorrelated with each other. If we talk about numbers, this is an incidence study that we conducted in South London at the time of COVID, before, during, and after COVID. And on average, the incidence of first episode psychosis in South London was 68 new cases for 100,000 population. Among this sample, 7.5% required psychiatric intensive care admission, which is equal to an incidence of PQ patients at first episode of psychosis of 4.7. Who is more likely to need psychiatric intensive care? So we explored these factors, and of course some factors are already known in the literature, so being a male, being an ethnic minority, index of multiple deprivation, use of cannabis, use of other substances, symptom severity, and functioning, diminishing of functioning, are all associated with a PQ admission. But PQ is just the last element of the chain, as we said. All these data justify the fact that some people need to be admitted to psychiatric intensive care. And so the point in terms of public health is trying to understand how can we do prevention. Let's start to just see what we can do when people are admitted to psychiatric intensive care. So psychiatric intensive care units are not present everywhere, are typical of UK, Australia, and some other countries. But in Italy, for example, we don't have psychiatric intensive care units. And these are specialized units that deal with violence and aggression, use a patient, or better say a person-centered approach, create, in our aim, of course, better experience in mental health, are useful for applying a public health approach, and respect every individual in their own right. So once a patient is admitted to psychiatric intensive care, assuming that, as said, the levels of symptoms is so high that we cannot manage the patient in other way, the highest level of restrictive practice in psychiatric intensive care is the use of seclusion. Seclusion is a room where patients are confined, is a supervised confinement in this room, and where the patient is regularly reviewed until is safe enough for the patient to come back to the normal world with the other patients. Of course, there are different ways to create a better experience in a psychiatric intensive care unit, but some are not very difficult, I have to say. Just the use of sensory lights, for example, and using a person-centered approach, what actually a patient feels is more likely to calm them down, has already a very good effect. But of course, we want to prevent seclusion. We don't want for people to have an episode of seclusion, because that is already considered a restrictive practice. And before going to that, of course, we have different principles that we can adopt. And the first one is de-escalation. So when a patient is violent or aggressive, the first step is always verbal de-escalation. Only after that we start with the use of medication. But actually you will see that at the Johnson Psychiatric Intensive Care Unit at the Moseley, actually we also implemented other steps before going strictly to pharmacological intervention and restrictive practice. And one of these, for example, is the sensory room, Sensory room is have the possibility to spend some time with sensory reflection towards disease supervised by nurse, specialized nurse, in the use of the sensory room. And this is one of the non-pharmacological interventions that can be used for de-escalating patients. We can do also research within a sensory room, try to understand why it's more effective in some people than in others, and this may have to do with the interoceptive awareness and sensory modulation. So by using a specific score, specific scale called maggio scale, we will see in a few months if actually there are a specific subgroup of people that are more prone to respond well to the use of sensory room. But sometimes, of course, a patient needs to be restrained, unfortunately. We don't want to arrive at that point, but the levels of violence and aggression might be very high. And again, there are different ways to do this practice. The wrong way is the prone restraint, because we know that is very dangerous for patients. And it's also not very dangerous in terms of risk to patient. It also is a trauma for a patient to be restrained this way. So during the pandemic, actually, we implemented a new practice of do restraint when was needed, which was through the use of safety pods that are disseminated through the units. And so if a patient is agitated, the restraint is always done using a safety pod. Of course, you can appreciate this from the picture, but when you sit in this safety pod and someone is holding you from the shoulder, it's almost impossible to get up because you are likely it is very difficult to get up from there. So, of course, it's still a restraint, it's still a restrictive practice, but it is not so traumatic as being restrained on the floor. Can we do something before arrive to that point, before restraining a patient? The answer is yes. The model that we adopted at the Moseley, at the Psychiatric Intensive Care at the Moseley, is 4 steps to safety. So we start with proactive care. Proactive care means that we don't wait for the incidents to happen, but we recognize, so the staff is trained to recognize early signs of aggression to manage risks. The second step is patient engagement. So we build a working relationship between staff and patients. We'll see in a while how this works. The third point is very important, is teamwork. So a PQ is based on a double leadership. We have medical leadership and nurse leadership. And it's very important, these 2 leadership communicate with each other. It is also very important that each information is not lost from one shift to the other shift. And we will see that there is a specific methods to avoid this to happen. And finally, the environment. We looked at something that we did on the Johnson Psychiatric Intensive Care Unit, but I always say we can do more on improving the environment. How proactive care works? It works thanks to the nurses. And I will never say thank enough to the nurse staff at the Moseley, because they, at the beginning, at the end of every shift, they measure the situational aggression for each patient using a DASA score from 0 to 7. This is very important because we develop different operationalized intervention based on the DASA score for each patient. And we also started for the first time to use the DASA score collected in routine clinical practice by nurses for doing research. So we realized that it's a very reliable measure for doing research, much better than any clinical records that you can extract. This allows also patients to be stratified in green, amber, and red zone. And why is this important? Because, of course, it changes the way we de-escalate an aggressive situation based on the starting DASA score of the patient. But it's also important because there is no something that you should always avoid in a psychiatric intensive care unit is leaving patients without a way forward. And so if you explain since the beginning that you start from a red zone, but then following the steps you can go to green zone and being transferred to an acute ward and being discharged, this avoids frustration, which we identified as one of the leading factor actually for being aggressive during the admission. Okay, let's go to the zonal observation project, which is this was one of the last project I led at the Johnson unit. Is any of you know this coach? Or Giuseppe knows him very well. Arrigo Sacchi. So Arrigo Sacchi was the coach of AC Milan in the 90s when AC Milan was basically winning any possible European competition. So it was really the strongest football team in the 90s. I won't say it was the president because we want to avoid any political claim, but Arrigo Sacchi was also important because he created a new way for the defenders to avoid that an attacker scored, which was what? Giuseppe knows it. It was the zonal defense. So how it works. So if you wait for an attacker, as a defender, if you wait for an attacker, it's much more difficult to stop them. If you instead of one defender to be against one attacker, and instead you place all defenders in a specific zone of the field, and of course if all defenders are trained, it works much better. And this is what we did at the Moseley, is the zonal observation project, because we realized that if a patient is on a one-to-one observation and is already a paranoid patient, actually having a nurse or a support worker continuously following you might increase your level of paranoia. Can you imagine you're already paranoid and someone is following you continuously? The level of paranoia increases. And so we decided to split the unit in different areas in a way that instead of each nurse following a specific person, when the person was moving from one area of the unit to another area, it was simply changing the nurse that was observing it. And I have to say, this was a pilot project, but the results were very encouraging. The second step to safety is patient engagement. And this has to do with what we call person-centered approach. What is a person-centered approach and a cultural-centered approach? In this specific area of London, the majority of the population are paradoxically ethnic minorities. And if you want to be, according to me, of course, a good psychiatrist in South London, you cannot live in Chelsea. You need to live in South London and understanding the culture of people that you take care for in that context. So you need to understand a bit of Caribbean culture, African culture, and so on. So for developing a real person-centered approach, it's important that the staff at the unit reflect the people that they take care for. And so, for example, if we have a Muslim patient, we allocate a nurse that is of Muslim religion. If we have a patient from Congo, we allocate a nurse that is from Congo. this simple step is part of the patient engagement. We notice that change a lot the outcome, because patients can share their worries or even, their culture with someone who is able to understand them. This is not enough until we don't move from doing something for the patient to do something with the patient, which is the next step forward for a good patient engagement. This means that when a decision is taken with the patient, is not taken for the patient. So we moved, this is an approach, of course, that is widely used across the UK. We moved from a sort of paternalistic approach to do psychiatry to a more human-centered approach, where you take decision with the patient, you take decision with the family, in a way that they are more involved in the medication that they are taking or the safety plan that we developed together. It's also important the trauma-informed approach. Trauma is very common in patients who are admitted to PICU, simply because trauma is correlated with violence and aggression. And I always recommend to collect a comprehensive history of the patient, because there could be some traumatic experience that we can address simply, again, by allocating a specific nurse to the patient in a way that is built a human connection and a trust relationship. Of course, migration is something that we discussed with Professor Ilaria Talicone yesterday. And it's important to understand that people coming from another country might feel isolated. So having the possibility of developing within an intensive care unit a human relationship with them may change drastically their outcome. There are two important aspects to consider that we learned actually from experience at Johnson PICU. The first is that there is a time in the most acute phase of psychosis when patients realize where they are and the psychotic episode that they had, that paradoxically they are more receptive to change. And so for doing good psychiatric intensive care, the team should be trained in recognize that moment that might last just a few days and use that moment to perhaps, together with the patient, plan some changes in the habits. Because you won't ever that opportunity again. It's only when the patients find themselves actually in the worst condition ever probably of their mental health that they're more open to change. And then we talk about teamwork. We use the SBART system to communicate from one shift to another or from team to another what is happening. So this is a very operationalized system, so situation, background, assessment, recommendation and decision, and risk escalation if it's needed. Finally, the environment. So the use of safe words might be useful. And again, understanding the place we work and how we can change things might reduce the risk of violence. What else can be done? Of course, any patients during admission, they have to spend their time in a proactive way. So doing physical activity is one of the best options because it reduces the levels of aggression, of irritability, and also it might help to counterbalance the effects of some antipsychotic medication, for example. Having planned activities throughout the day is also something that helps to reduce levels of violence and aggression and helps also to engage with patients. Okay, let's go to the biological part of this talk. I'm just skipping some slides. If we think about cannabis, we saw how it is related to have more positive symptoms. But it's important also to understand the biological context where cannabis acts. So the endocannabinoid system is composed by, as you know, CB1 receptor for cannabis, and for anandamide, which is the endogenous endocannabinoid, and it serves to modulate synaptic transmission. It is very important for some particular function, including modulate mood, modulate sleep, appetite, and it's also important for neurodevelopment, especially during adolescence. So, if we consider that cannabis increases the risk of psychosis in a dose relationship fashion, as we saw, you can see in this graph how people using cannabis on a daily basis experience more positive symptoms. The question is, would they develop more positive symptoms regardless of their genetic score for schizophrenia? So we try to do an interaction model, putting together the use of cannabis, a polygenic risk score, so an individual susceptibility for developing schizophrenia based on common genetic variants. And what we found here in the UGI study was that these two factors were independent from each other. So if people were using more cannabis, they had more positive symptoms. If they had a higher polygenic risk score, they had more positive symptoms. When we modeled these two terms together, there was no interaction. These two lines do not cross each other, meaning that these are independent from each other. So we can conclude that if you have a higher polygenic risk score, you may have more delusions and hallucinations. If you use more cannabis, you can have more delusions and hallucinations, but there is no interaction with these two terms. But what happens when, instead of using the entire genome as we normally do with the polygenic risk score for schizophrenia, we just use a genetic pathway of the endocannabinoid system, which makes more sense because cannabis acts on the endocannabinoid system. So the situation here changed quite a lot, because you can see that, again, these two factors are associated with more positive symptoms, both the genetic risk of schizophrenia based on the endocannabinoid genes and the use of cannabis. But when you add these two factors together, you get an effect that is higher than the sum of these two single factors. This means that one factor amplifies the effect of other. So this is an additive interaction, which means that, it is true that not all the genome might make people more susceptible to develop psychosis if they use cannabis, but when we restrict this to the genes of the endocannabinoid system, yes, we can find actually that some people might be more vulnerable, which in my opinion is a very good news, because perhaps in the years to come they might develop some therapeutic target based on the endocannabinoid system. Why is important the endocannabinoid system and the cannabis in a PQ? For a different sets of reasons. The first is that cannabis, we need to distinguish cannabis intoxication when people are experiencing psychotic symptoms due to the acute effect of cannabis. And in this context is more evident the psychotic violence within a PQ environment. Cannabis withdrawal, in my experience, is less rare, because when we see that patients might become more irritable after some days that don't use cannabis, yes, it might be that they're withdrawing, but it also might be that there is some frustration because they actually crave for more cannabis. So what we call cannabis withdrawal very often is craving for cannabis. Of course, cannabis increases the levels of positive symptoms and increase the level of violence. So if we put these three factors all together, we have basically the three elements that leads to the increase of the need of using a PQ setting. Okay. Another data that I want to show you is that once a patient is admitted to a PQ, if they are cannabis users, the risk of being secluded of an episode of seclusion is higher than the counterpart of patients that don't use cannabis. So cannabis is not only associated with an admission to a psychiatric intensive care unit, but even within the psychiatric intensive care unit, those using cannabis have usually a more traumatic admission experience. Okay. Just a few more data on follow-up. We have 5 minutes left. We have a very good cohort of patients in London, which is the GAP and UGI. These are patients that developed a first episode of psychosis between 2005 and 2012, roughly. So there are 2 different studies by using the same methodology, and we conducted a follow-up study. So here we just explored if there were some factors associated with admission to hospital in a 10-year follow-up, and we could see how the use of cannabis was associated to a higher risk of being readmitted to hospital. But this odds ratio increases a lot and is almost 7 times higher for people going to a PQ, meaning that if you continue to use cannabis after a first episode of psychosis, so not only you are more at risk, at least in this cohort, of being readmitted to hospital, but the admission would be more likely in a PQ setting. What about symptoms? Again, we can see the same patterns that we saw before in a dose-response relationship with people that did not have relapse and not using cannabis. In green, they're also the ones experiencing less symptoms in general, whereas people that had the highest level of positive symptoms were the ones that were using cannabis and had a relapse in a PQ. And for all these categories, the green, the yellow, and the red, you could see how those using cannabis always had more symptoms than the ones not using cannabis. Final slide is about, this is still the follow-up study. So here we looked what could again lead to relapse in a PQ, but also adding some biological data in terms of polygenic risk score. And we built 2 polygenic risk score, one for schizophrenia and another for impulsivity. Because another psychopathology area where cannabis acts is on impulsivity. Again, of course, cannabis was one of the factors, among others, and we could see how, sorry, we don't have the odds ratio here, but how the use of cannabis was the factor associated with the highest likelihood of being readmitted to PQ in the 10 years after a first episode of psychosis, followed by treatment discontinuity. And this is an environmental load that we created, putting together the various elements of the syndemic approach, including the situation, the living situation of the patient and the index of deprivation. Of course, having more symptoms was also associated to a relapse in a PQ. And the polygenic risk scores, both the one for schizophrenia and the one with impulsivity, were both associated with actually high risk of relapse. But as you could see here, the effect size was lower compared with environmental factor. This actually is a very good news for us because it means that, of course, it's easier to do prevention on risk factors such as cannabis use or the social context than biological factor. Okay, thank you very much for your attention.
Thank you, Diego. There are 5 minutes for questions. Are there any questions?
Thank you, Diego, for this interesting presentation. I would like to know how you treat withdrawal from cannabis to avoid escalation in acute patient in your unit.
Thank you. That's a wonderful question. We don't have any medication for withdrawal from cannabis, but at Johnson Pickey we developed a specific protocol based on the use of benzodiazepines. So we use, for example, in people that we know that are withdrawing, we prefer diazepam compared to clonazepam. And there is some data that actually show that this might help. But the best way, again, for cannabis withdrawal is prevention. So something that we did was to train the team for recognizing early the signs of withdrawal symptoms and to inform patients. We did this project specifically a few years ago. So the whole team was trained in administering a scale for measuring cannabis withdrawal symptoms, and at the same time informing the patient at the admission if they were their users of cannabis, that 3-4 days after admission they could have experienced the withdrawal symptoms. And that worked in a way that somewhat patients were able to recognize that perhaps their irritability was due to having discontinued cannabis and so on. Another project that we started but then we could not complete was the use of sensory room for withdrawal symptoms. Unfortunately, that was quite complicated, so we could not complete it.
Hi, thanks, Diego. I have a couple of questions. So one would be about the increase in number of psychotic patients in the latest years, probably associated with cannabis use. And I was thinking if you think there is any influence about the prescribed cannabis, which seems to happen quite a lot, at least in my area, seems to be quite a lot of clinics that prescribe cannabis for a variety of things, and I'm never sure what exactly they're prescribing. It seems to be to high doses, like 3 grams a day or something like that. And the second question was about the sensory room, and I was wondering, did you have like a room designed like this in the PQ unit, or all the rooms look like that? And also if the patients were asked, well, you can't actually ask them, I guess, when they're in acute phase, if they prefer one or the other, because I'm thinking that some might find it upsetting or patronizing or, something like that.
Yeah.
Thanks.
So thank you for the question. So regarding the first one, the use of cannabis, I mean, the association between cannabis prescribed, I think for medical reasons you meant probably, and the increase of levels of for other reasons. It is a risk. Cannabis is a substance. It's more or less, I think, we need to pay the same attention that we do for using stimulants in ADHD. So it's not for everyone. And we need also to consider that at the moment the current evidence is that cannabis is not good, or at least the risks outbalance the benefits for all the psychiatric phenotypes, from anxiety disorder to depression. So it is not the right medication. For sure, it may have a role in the increase of the incidence of psychosis, but we do not observe it in South London, because South London is not an area where people usually go to the private psychiatrist and get a cannabis prescription. So we need to ask for people living in some other areas of London. Regarding the use of sensory room, so that's based on the patient preferences. So it's not for everyone, and so it's entirely up to the patient. If they feel like a bit irritable on that particular time of the day, they know that they can spend some time in the sensory room following some rules with the occupational therapist who is trained actually for using the sensory room. And that was, we built it at the Johnson unit a few years ago, but now there are other sensory rooms that were also built in other PQs at the Moseley. So I think at the Moseley now most of the acute intensive wards have a sensory room. Yeah. It is separate. I get your point. The reason why it looked similar is that then after building the sensory room, we thought, why we not use the sensory lights even in the seclusion, and music even in the seclusion, and that actually worked. But they are two different rooms.
Thanks for a good presentation, Diego. Just a quick one. I wondered if you'd seen much impact from the synthetic cannabinoids such as spice in your area?
Yes, especially for people. So something that I've not mentioned, because of course there was no time, that 30%, up to 30% of patients admitted to PQ might be forensic patients coming to prison. And this has increased a lot in the last few years because there is no space in prisons, and as a consequence, there are more patients that were transferred to psychiatric units, unfortunately. In that particular population, yes, the use of synthetic cannabinoids is common, and we usually see patients who have this very acute presentation in the first days of the admission. But the good thing about this very acute presentation is that using the right medication, the right doses, usually people might recover, and the rest of the admission goes quite well. And this also reminds me to distinguish two patterns of patients that we saw at PQ. So there are patients who are immediately aggressive at admission, and usually are patients coming from the place of safety, or from the police, or from prison, or from cannabis intoxication, or stimulants, and so on. And usually they may have psychotic violence at the beginning, and then after treatment, pharmacological, non-pharmacological treatment, they recover quite well. The second population of patients were patients who are actually quite calm at the beginning of the admission and might develop aggression and violent behavior after a few weeks, which apparently are related to the use of substances. Even sometimes they are able even to use substances while during the admission. And this is due to the fact that there might be some other impulsivity traits and frustration, and there might prompt frustration. And that is another type of violence, which is antisocial violence.
Robin, there was a question over there before you. Yeah, okay, a quick follow-up, and then.
The advice would be prevention, just to avoid drones and other ways for bringing drugs to prison. I think that's terrible. I think in prison there is the biggest limitation is that you cannot restrain patients. So if a patient say no to a medication, you cannot force medication. That's why then the PQ intervenes.
That's question.
Diego, I was wondering, now that you've been back in Palermo for a little while, do you think that there is less violence among psychotic patients in Palermo, and is that cannabis related, or less child abuse, or what do you think?
Yes, there is less violence in Palermo, even though we observed quite severe presentation in the emergency department, but not at the level of South London.
Do you have a PICU?
No.
So
not yet.
Where do they go?
So they are transferred to locked wards that are outside the polyclinic in Palermo. But unfortunately in Italy they still tie patients. So if patients are quite aggressive, as actually in many South European countries, they still, unfortunately, they tie patients to the bed until they calm down. And this is something we aim with the Palermo team to work on. Implementing a psychiatric intensive care unit with a seclusion room would avoid actually to have to restrain a patient in their bed. So
do you think this is related to less violence amongst psychiatric patients, what are the rates of violence in the population? Why do you think is there more violence in South London than Palermo, in spite of the reputation?
But you said right, it's a reputation. In my opinion, London is more dangerous than Palermo. So if you walk in Brixton or in Camberwell at night, I very often meet some people who are very violent, or because of psychosis, or they are patients and so on. It happens very often. In Palermo, I mean, I never saw patients so violent in the street at nights, but perhaps it depends also on the area.
So we have time for a very quick question, last question, and then the break, and then the workshops. There was a question over there. Oh, okay, perfect.
I'm not so sure I can be so quick, but regarding, I saw the slide on the NHS guidelines on rapid tranquilization, and we don't have any in Italy. So I was wondering if you have any thoughts about that, because in my very limited experience, I'm a trainee, I saw that common practice in Italy can vary a lot. It can be very different from what it looks like from the NHS guidelines.
Yes, you're right, it's completely different. I mean, within the psychiatry school in Palermo, we will do some teaching. Actually, we plan that since last year to do some teaching on how to manage violence and aggression in A&E. But it would be good, of course, to use the Mosley guidelines, or at least to import in Italy the Mosley guidelines for managing violent behavior, definitely.
Okay, thank you, Diego, for splendid talk.
Thank you.
quindi l'hai messo proprio alla fine, dopo le mie diapositive?
No, no, nella sua presentazione. La chiudiamo e poi...
Va bene. Okay, let's start again with this workshop regarding party drugs and mental health. And please, let's try to transform this section in an interactive section. So if you have questions also during the presentation, please do. And let's start going in the middle, trying to look at some specific substances. Here we have just some examples to better understand the topic. Bromo dragonfly. What is this substance? Of course, probably you should not have any idea of this substance, because it's not that common in the clinical practices to have a patient saying, I'm taking bromo dragonfly. It's quite uncommon. But in many cases, patients are taking bromo dragonfly without knowing about the fact that they are taking bromo dragonfly. It's a classical party drug. It belongs to a group of psychoactive substances derived from phenethylamines. We are in the middle between psychedelics and stimulants, something in the middle. It's known as fly drugs because you can see the chemical structure. It looks like a fly with the specific structure. But why I'm starting with this example? Because this substance with the hallucinogenic and entactogenic effects has some specific effects that can last up to 3 days after a single dose. So, for example, if today in your inpatient unit you have a patient that is showing many symptoms without an explanation, it is possible that this patient had a specific intake of this bromo dragonfly in the 3 days before. 2-3 days of length of action. Well, why this? Why are they producing something like this? Because, for example, if I want to go to a rave party, and in order to have something that can stimulate myself for a longer period, this could be something very useful. So they are designing, I'm using this term because this is technically a designer drugs, they are designing a specific drug with these characteristics. I had the question there. Please again, because also from with the connection away.
Sorry. I have a question, I guess, about Italy and the UK. Is that any person who presents to our emergency department with first episode psychosis, so like this, we would do a urine drug screen. If amphetamines and THC are negative, we would do a full toxicology screen, and so we would know that this was B-fly. I haven't seen B-fly for a long time, but we see other designer drugs relatively recently. Is that not something that gets done other places?
No, I mean, in Italy it's really uncommon to have more than the four sisters: opiates, cannabinoids, stimulants, and cannabis, opiates, stimulants, and benzodiazepines. These are the four that you can find in every hospital. But apart from this, we have a couple of specific toxicological centers in Italy when you can send some samples, but it's not that easy. It's not something that is that we are doing every time. So it's quite difficult to get this information. So this is very good that we have this opportunity, because trying to know what the patient is taking is very important also, because in reason of this you can decide which can be the right pharmacotherapy, at least in the acute phase. So thank you for... Okay, quick enough? 1 week could be?
Yeah. Sometimes it might take 5 or 6 days to come back. So in the acute phase, it's not that helpful. But when you're trying to distinguish between an enduring psychosis or a drug-induced episode or plan for the future and plan for follow-up, if somebody comes up positive with this within a week of them coming in, then that's actually going to change the way you counsel them, change the other support you're going to give them.
Also because, for example, knowing that a patient is taking Bromo Dragonfly with this effect lasting days, you can start to hypothesize that this is still a transient situation, because otherwise I should start thinking that it's something that is chronically psychotic. So to understand which can be the substance behind could be very important. Let's see another example. Okay. 25C N-Bomi, also called in the street N-bomb. Why I'm doing this example? Because N-bomb, this is a hallucinogen from the lysergamide class. And this is a serotonin 2A receptor agonist. So it's a very specific substance, extremely potent. Just a few micrograms are capable of producing substantial effect, so high potency. But why this can be very important? For one reason. First of all, why are they producing something that is working in micrograms? What do you think could be the reason behind this? Why producing something that can be effective in micrograms? Oh, please porta with the microphone because they need to understand. Prego, prego.
I was just saying that you can carry massive amounts in a very small pack. It's easy to distribute.
That is the most important point. Which could be the issue connected to this point? The issue is that, for example, if I am a drug dealer and I'm going outside in the Palermo Square outside and I'm selling 25 N-Bomi to someone that is asking for cocaine, and I'm giving to this subject a quantity that can resemble that of he's usually taking as cocaine, probably is going to take half a gram, 1 gram, thinking about cocaine, but then we have something that is more potent. So the effect in terms of psychiatric consequences could be dramatic. Also because the dealer, in many cases, doesn't know that what he's selling is N-Bomi or another substance. So this could be another issue behind, another reason behind the possibility to have a psychotic episode. Over there, another hand.
Thank you. Sorry, on that point, is it not related to the molecular weight of the molecule? I'm just thinking about clonazepam. Clonazepam is also in micrograms. Yes, it could be due to basically selling large amounts, but could it be other reasons?
Of course. No, it is correct. But one with this example, I wanted to emphasize that possibility of the specific use that the drug dealer are doing with these concentrations. Then another point, another example, the 4-fluoroamphetamine. This is called as the baby ecstasy, the ecstasy light. Why I'm saying this? Because behind these substances we always have a specific misleading marketing strategy. For example, in Italy, a substance that is very popular at the moment is the pink cocaine, but it's not cocaine. It's something in most of the cases different, or in other cases is a simple cocaine with a lot of color inside, but it's not something that is specific with that kind of effect in terms of purity, in terms of reward. It's only marketing that is misleading. So this is another point that we have in this party drug market. Now let's give a look at this video. This is a young adult, no, I would say an adult. Here we are in Ibiza. We are outside a pool with a disco in the same environment. We are in the morning, but after a night of music and after an aggressive episodes with the...
Tranquilo, Jul, tranquilo, niño, tranquilo.
Tranquilo,
Tranquilo.
Relájate.
No hagas nada.
¿Español?
Sí.
¿Cómo se llama?
Aitor.
Aitor, relájate.
Relájate, no hagas trices, cabrón.
Aitor, mírame.
Mírala.
Oye, chicos, que si vais a estar aquí riendo, no necesito que estéis...
Vale. Tienes razón.
Aitor. Vale, 99.1.
¿Estás jodido? Si bajara un poco la música, a lo mejor es por la música que te...
GHB, ¿y qué más?
Se ha tomado una Viagra y todo, y 25 cubatas por lo menos.
Una Viagra.
Sí, yo tampoco lo entiendo, pero... ¿Cómo tiene el pulso? ¿Bien o mal?
Bien. Aitor, bebe agua.
Ah, no, tranquilo, Aitor, tranquilo, te está ayudando. Mira, está ahí, está de puta madre. Tranquilo, Aitor. Tranquilo, ahí, ve eso. Vale, bebe agua.
Aitor,
Estás en Ibiza.
mírame. Vale, estás en la enfermería, tío. ¿Vale? Venga, bebe agua. Vale, esto no puede beber agua.
Ahí ya está mejor. Solo falta el espasmo que se te quite. ¿Y por qué le dan esos espasmos?
¿Eh?
¿Otro desahogado?
¿Cómo? ¿Dónde?
No, quieto, Aitor, quieto. Quieto, espérate que te encuentres mejor. ¿Qué se ha ahogado una niña?
¿Qué pasa? No pasa nada. Enfermería.
Venga, vale, ya está.
¿Te voy a ayudar? Por favor, podéis repetir que habéis dicho de una ahogada.
They are saying keto, which that in Castellano means calm down, because 5 minutes before he had a very serious episodes of violence, and he's staying there, and after a while he was brought to the hospital, and the urine sample was negative, and he had these episodes of 2 hours of violence, aggressivity, and then this specific status when you can see this, I would say, dissociative state, which could be the hypothesis behind this situation in terms of typology of substance. PCP, phencyclidine, could be an idea. Why are you saying this? Okay, could be an hypothesis, but urine sample negative.
Given how diaphoretic he is, he's a bit rigid. I think that if we actually did a neuroexam on him, he'd have some clonus on there. I'd be a little bit worried about serotonin syndrome with him, so probably a designer serotonergic, and probably need some IV fluids and maybe serotonin antagonism.
Could be an idea, of course. Other possibilities? Other ideas? Bearing in mind that urine sample after 1 hour negative. The hypothesis at the beginning was something like could have been a catinone, but also a synthetic cannabinoid. But at the after the possibility to speak with friends and other members, we managed to understand that it was the case of GHB. That is quite common in Europe at the moment. And GHB is a synthetic analog of the gamma-aminobutyric acid, and it is commonly used by bodybuilders and nightclub goers. it's able to increase the release of growth hormone, and it can determine euphoric effects. In Italy, we have GHB also as a possible medication. The commercial name is Alcover, that is indicated for the treatment of alcohol dependence. But apart from this, GHB is commonly associated with euphoric state. They call that the liquid ecstasy as well. And we can have some specific symptoms, and among these, confusion, urinary incontinence, tremors, hypothermia, and other possible very serious effects as well. And the GBL is the derivate, synthetic analog. That is another substance that we can also find in the disco as a party drugs. Okay. And it is very interesting that the GHB and GBL are not detectable in the urine samples, because apart from half an hour, 1 hour after the intake, is something that is vanishing in 1 hour and a half, a couple of hours. And this is very important also for other reasons. And now I think we have another video. Please give a look at this. Did you see that? Again? It is a substance that is commonly used to produce intoxication. After half an hour, 1 hour is going to reach its peak. And the good point is that you are not going to find that in the urine sample, so in most of the cases they are using that. They call this drug as a date rape drug as well, and this is commonly implicated in these cases. So it is a party drug for many reasons, and one of these is this as well. Okay, now, after these examples, we could speak about MPS for hours. We have at the moment, more than 1,500 new psychoactive substances that have been described. So just try to give some examples. But now let's give a look at how to manage emergencies and treat a psychotic patient, like the case of Heitor with the substance use disorder. So first of all, the risk assessment. First of all, before doing anything, we need to do a risk assessment. It is important to give a look at some specific clinical signs. Of course, it could see something that is obvious, but I mean, we need to look at the persecutory delusions, the presence of auditory hallucinations and manic symptoms and so on. And also, looking at the patient history, we have some characteristics that are associated with violence, like being male, young subject, low socioeconomic status, limited social and family support, a previous history of violence, recent stressors, and so on. Of course, again, it could look like something obvious, but it is very important to think ahead before trying to treat this kind of patient. Also, the environmental factors are very important. That point, limited physical space, we need to think about this point before, not after the evaluation and during the evaluation. So before entering in a specific situation, I need to think, where is the entrance, where is the exit, how big is the place? If I'm doing this evaluation before, then when the patient is going to show some violence, I have in my mind that the exit is over there, because otherwise in that specific moment I'm not able to understand where is the exit. So this assessment is very, very important. And of course it is important to do the de-escalation verbal de-escalation, the use of distraction techniques, the removal of precipitating factors could be very important. In a situation of de-escalation, it is important to stay at a good distance from the patient, trying to speak in the right way, of course. It's not an easy approach. Nurses are better than us in many cases, but a good approach can dramatically change the situation. Okay, after this, after the risk assessment that we have to do before and after the escalation, we need to treat the patient in many cases. So let's try to think about a clinical situation. We are in the emergency setting. The patient is showing symptoms of aggression, violence, psychotic symptoms, hallucination, delusions, psychomotor agitation, and now we have to decide what to do. In many cases in Italy, for example, in these cases the psychiatrist is an active part. Of course, we have the medical doctor in the emergency department that he is always asking for the psychiatrist to take decision about this. So we need to try to understand which could be the right drug, and in many cases without knowing which is the substance that the patient is taking in that specific moment. So I can propose some options. This is, of course, my practical situation in Italy. Every country has its own medications, so it's a good point to discuss. But first of all, I would say a benzo. And of course, why a benzo? Apart from those cases where we have a respiratory issue with an alcohol, a very high level alcohol intoxication, but apart from this, the use of benzodiazepine is probably the best thing we could do, because we are not altering the QT interval, we are not determining possible pharmacodynamic interactions and other points. Lorazepam could be probably the best one. Why this? Because the hepatic passage is not that important with the lorazepam. And in many cases, that could be an issue because they are intoxicated, they could have some hepatic issues for alcohol and so on. So the use of benzo and lorazepam could be the right choice in many cases. But of course, if you have experience with other benzos, of course, this is something that can be good as well. I would avoid, for example, diazepam intramuscular, because it's not linear, the absorption curve, so in many cases can be erratic, the pharmacokinetic, so it's better using, for example, lorazepam. But in many cases, the situation is not manageable just with the use of benzos, and in many cases, of course, we can use midazolam as well, but the effect is very rapid. But in many cases, we need to use something that can be more specific for the psychotic features. For example, in my experience, we are using aripiprazole intramuscular administration, which is something that is completely different from the oral aripiprazole. The intramuscular administration has a specific pharmacokinetic that is very, very rapid, and the possibility to calm down the patient is, I would say, the opposite that with respect to what we are observing with the oral formulation. And in many cases, it's doing very well, also because aripiprazole is a very good drug in terms of QT intervals, is not having a specific cardiotoxic effect and so on, and so it could be an idea. Please.
LAI. Giovanni, can I just confirm, is this the aripiprazole LAI, the long-acting formula?
No. Rapid action. It's not the LAI.
Yeah, we don't have that one, so this is interesting.
Okay. No, it's a very good rapid action, active antipsychotics, and it's also really economic on the pharmacoeconomic point of view. So In my clinical practice, lorazepam and aripiprazole are the first two things that I'm doing also together with a patient with an intoxication mediated by the use of substances. The dosage is 7 milligrams. And you could do after 3 hours another dosage, and then again for 3-4 times without any issue.
Oh, thank you, Giovanni. One thing is about the intravenous. I mean, in the UK, we don't use usually IV benzos, but just because you need, I mean, you cannot do it in NI. But I was wondering, but if the patient is agitated,
no, of course, if the patient is agitated, it's just the case for the intramuscular, of course. No, I just put on the diazepam intravenous because the intramuscular is not working well, as you know. But apart from that, the possibility to use the intravenous administration is very uncommon. Absolutely, of course. Then, other possibilities. Promazine. I mean, of course, it is a typical antipsychotic. We can have some interaction with the D2 receptor, specifically with cocaine in some cases, but it's quite uncommon to have immediate side effects. So I would say that in many cases could be a good idea, also because promazine, as you know, can have also antihistaminic effects, so it's calming down, also acting with another mechanism. So in this situation, covering different systems can be very important. Benzo on the GABA, and then antipsychotics on the dopamine, and then antihistaminics. So acting on different systems could be more relevant than using the same specific drug acting on the main one. So changing the system can be very important, and also the use of valproate is another way, a completely different way to calm down the patient. Valproate, of course, here in the we need to try to use this possibility that, of course, in Italy this is not possible for. It is off-label because we should use valproate just for those cases of epileptic seizures. So it is an off-label use, but of course in an intoxication you can justify the use of something that is against the epileptic seizure. And in my experience, it's something that is working properly in order to calm down the patient. Please.
I would be interested to know about what your thoughts are on droperidol, because our policy is that anybody presenting like this, the ambulance would give 10 milligrams IM, then wait 20 minutes and then give another 10 milligrams IM, and that's being rolled out across our whole country.
I don't have a specific experience with that because it's not available, but could be. Tell me something more about this. How are you using that?
Yeah, so droperidol is very similar to haloperidol, but it's more sedating. So it gets used as a first-line agent for any patient with agitation that there is a suspicion of psychotic symptoms, although in reality, anybody apprehended by the police or the ambulance that is violent and not de-escalating in New South Wales gets put under the Mental Health Act, given droperidol and conveyed to hospital. Depending on how antipsychotic naive that person is, they may be sedated from anywhere between 1 hour and 12 hours, in which case they spend that time in the emergency department, and once they wake up, they get a psychiatric assessment. With the designer drugs, so things like GHB, some of the serotonin agonists that people take, often that means that intoxication period resolves by the time they wake up. But in Australia, we don't have IM aripiprazole or promazine. We do have IV sodium valproate, but I think we would be hard-pressed getting the emergency department to use it for anything but refractory epilepsy or status epilepticus. But yeah, droperidol was a drug that New South Wales Health initially, and then the other states actually marketed specifically for ambulances. It's not available anywhere else other than a hospital and ambulance setting.
Thank you very much. Very interesting. The only possible interaction that I could think in the scenario of substance use could be with the specific dopaminergic agents like cocaine, when we have a very super stimulant effects on the D2 receptor by using a blocker. So in that case, we could have some very strong reaction like dystonic cases. But apart from this, could be a very interesting point. But unfortunately, in Italy, we don't have this drug available. Please, Diego.
That's not available in the UK either, but something that is used is olanzapine IM.
Olanzapine IM, of course. Good idea. Available in Australia?
Our ambulance protocol is they give oral, or like olanzapine wafer first. If they won't take the olanzapine wafer, if that doesn't work, they give droperidol. The protocol is drop midaz, so they get 10 of droperidol, 20 minutes later another 10 of droperidol. If that doesn't work, 10 of midazolam. And by that point, they're usually in a resus bay of a hospital. And so we will then go through our procedures to sedate them. But droperidol, I guess it's probably been the last 15 years in Australia, but it got rolled out in one state and then spread everywhere else. When I first started my training, it used to be haloperidol and midaz. But generally they found that, we occasionally get an NMS case from droperidol, but I think I've probably seen 3 in 10 years. So, I guess it's relatively safe, but on people who are very high on GHB or large amounts of ice, generally you need multiple doses. But you would need multiple doses of anything.
Of course. Thank you.
Does it change any?
Yes, there is a risk of QT prolongation, not as bad as haloperidol, but the protocol post 10 milligrams of droperidol is once they are sedated enough to be able to safely do an ECG, everyone gets an ECG. So the emergency department is aware straight away if that's somebody who's actually having ECG changes.
Very interesting. Thank you very much. Here, for example, some data regarding the use of the intramuscular midazolam and lorazepam on the acute agitation in non-elderly subject. And for example, this review indicates that the combination of one of these intramuscular benzodiazepines with a low-dose intramuscular antipsychotic is more effective than either the benzodiazepine or the antipsychotic administered as monotherapy. So a good idea since the beginning is to use both the approaches on the two systems. Here is something about the emergency, no? Use and feel. The result here they are speaking about the safety of valproic acid versus haloperidol, saying that the use of valproic acid could be a good idea instead of using haloperidol in many cases of agitation. Okay, now let's move on a different situation. We are not in the emergency, but we are, for example, in an outpatient clinic, and we need to treat a patient with the use of substances together with psychotic symptoms. These could be directly induced by the substance, or in other cases could be something that is going on its own. Of course, these situations are always in the middle, but the clinical picture is that a patient with psychotic symptoms and the use of substances. Now, before speaking about which can be the best pharmacotherapeutical option in terms of antipsychotics, when we are in front of a patient with the use of substance, we need to bear in mind this model. We need to understand where the patient is. Because if the patient is in a situation of pre-contemplation, where there's no intention of changing behavior, the only thing that we could do is that of doing harm reduction, trying to do the best we can, trying to do psychoeducation. But apart from that, if the patient is not starting to enter the contemplation area, where the patient is starting to be aware that a problem exists, but still the patient is in a situation where there's no commitment to enter in the action. The good point is it could be that of entering the preparation phase when the patient at that point is ready to change. So in that case, we can try to say, okay, we could start a pharmacotherapy, we could start a psychotherapy, a group therapy, you could go to an inpatient unit and so on and so on. Because otherwise, if you are proposing something to the patient when the patient is in another status like the pro-contemplation one, at that point we are losing time and we are proposing something that the patient is not able to do. So trying to understand where the patient is the base of every specific treatment. We call the pro-contemplation phase like the honeymoon phase. In this situation, the person has no intention of changing and is completely unaware of their pathological condition or the associated risk. He can only see the positive effect of the substance. It's like being in the honeymoon. Everything is good about the substance. Motivation is lacking. Others may recognize the problem, but the individual minimizes it. Can we do something in this situation like this? Yes, of course. We can start to do harm reduction, trying to say that, okay, now you're thinking this, but we have this data, we have these possible effects. Try not to use large quantities. Try to avoid the use together with other substances. Try to avoid to use car. It can be important. I do think that also in this situation we have a role as psychiatrists. Then we have the contemplation phase, where the individual begins to consider the possibility to change. Begins to consider, is not committed to change. We can still try to do some harm reduction, promoting and emphasizing the possible good aspects connected to the change. And also exploring potential therapeutic alternatives. Okay, you are not ready to do something, but if you are going to think about quitting the use of substances, we could try to do this specific therapeutic program. We could start a pharmacotherapy. We can help you to reduce these symptoms that can be correlated to the substance. Starting to explore potential therapeutic alternatives. Then we have the determination or preparation phase, when the decision to change has been made. Here we have the awareness of the negative aspects of the previous behavior that outweighs the perceived benefits. Now the patient is ready. And it is very important to act as soon as possible, because the patient, this motivation phase is something that is vanishing in hours, days, or weeks. So at that point, we cannot say, okay, very good, next time we will continue to discuss about this. No, we need to start with a proposal today. Tomorrow you have to enter that situation. You need to start a pharmacotherapy. We cannot wait. So strengthen that awareness and promptly support the development of concrete and practical strategies. And then we have the action phase, when we have the therapeutic goal to reinforce and support the change, emphasizing the negative aspects of the previous behavior. And then the maintenance. And of course, because that of the addiction area is something that is per definition relapsing, we also have the relapse that can be something that we have to manage with care. Okay, after this, looking at the specific phase of the disorder, in many cases we have the possibility to treat the patient. And when we have the presence of an addiction issue, but we have psychotic symptoms, a good idea could be that of treat the patient with the antipsychotics. In this systematic review, we try to give a look at try to answer the question about which could be the right antipsychotic for these situations. First of all, of course, I would say that a typical antipsychotic should be prioritized for dual disorder cases. Why these? Because, for example, let's think about haloperidol, a wonderful substance, a wonderful medication, but we are inhibiting the D2 receptor, and this, of course, is good in terms of psychotic symptoms, but we are also inhibiting the reward system. And if you are going to inhibit the reward system, of course, the patient is going to feel a higher level of craving because the system is stuck. This is the reason why if we think about the old patient with haloperidol, one typical thing is that of using tobacco and caffeine in order to reverse that specific antagonism in the reward system. So to some respect, would be a good idea to use a typical antipsychotics and partial agonists. Partial agonists, as you know, in the mesolimbic system can act reinforcing the system, and inhibiting the system, and in the mesocortical system can act stimulating the system. So can regulate the dopaminergic system, adjusting dopamine levels in regions where they are elevated and enhancing dopamine levels in other areas. So this could be important. Looking at, we try to differentiate first-line treatments and second-line treatments with the exogenous psychosis. So among the first-line treatments, we should consider ABC, the partial agonists, aripiprazole, brexpiprazole, and cariprazine. And this is because we have a partial agonism effect at the D2 receptor, but also because, for example, for aripiprazole, we have the blockade of the serotonin type 2C and 7 receptors that can have some antidepressive effect. So we can have some specific effect mediated by the interaction with the different receptors that can be of help also in the management of craving. Among the first-line treatment, we do also consider quetiapine and olanzapine. But of course, as we know, on the long run, this could be an issue in terms of weight gain and other possible effects. But in terms of specific effect on craving and so on, that of quetiapine and olanzapine could be a good idea also because today we discuss about the importance of the circadian rhythm that in most of the cases, I would say 100% of the cases, are not functioning in the right way with patients with the use of substances. So using quetiapine and olanzapine can help us to regulate that situation of agitation and insomnia. And of course, the use of LAI could be very important. That of compliance is a crucial issue with these patients. They are not using medication in the right way, so the possibility to use LAI could be important. As second-line treatments, we mentioned the use of DONES, paliperidone, risperidone, lurasidone. Why as second-line treatment? Because, of course, we are blocking too much, probably, the D2 receptors. And as I've said, with the case of haloperidol, the mechanism more or less is that. We are blocking the reward system, and this could be an issue. But from the other end, if the psychotic part of the situation is the more relevant, probably this second-line treatment could become first-line treatment because that of the psychotic syndrome is predominant with respect of the part related to the use of substances. Some data regarding, for example, lurasidone could be of interest. Looking at the role of partial agonists, we know that in cases of mesolimbic dopaminergic overactivity linked to positive symptoms, the partial agonist competes with dopamine 4 receptors, and this competition displaces dopamine, so decreasing the system excessive activity and returning it to a physiological range. And then in terms of adverse reaction, we have, of course, a good profile, so also in terms of hyperprolactinemia. And then, probably this is the most important point, partial agonists may bolster weakened dopaminergic transmission in the prefrontal cortex. And this is very common for those subjects using substances where the system, for example, after the withdrawal is understimulated. So it could be a point that we should take into account. This is the classical situation there where pulsar agonists stimulate or dampen the transmission, of course, depending on the specific context. In a situation of low tone, the agonist property prevails, and in a situation of high tone, the antagonist property prevails. So this could be the reason why this kind of drugs could be important. Here we have some data. I'm going rapidly because it's simply a simple description of the possibility to use brexpiprazole. I don't know if, for example, brexpiprazole is available in Australia. It's available? Available. Cariprazine? Available. Good to know. We have good data about this specific role about brexpiprazole. Okay. For example, this is a case of a remission of persistent methamphetamine-induced psychosis after cariprazine therapy. Why cariprazine can also be something different from aripiprazole and brexpiprazole? Because of these, because of the D3 receptors. We have some mice studies relating to a specific effect, anti-craving effect that could be mediated by the D3 interaction. This is something that is specific for cariprazine and not for aripiprazole and brexpiprazole. Here you can see the different ratio between the receptors, and in terms of D3, D2, but specifically on the D3 prevalence is the effect of cariprazine that is different from that of... we have some good data relating to cariprazine. I cannot say that is 100% better than and different from aripiprazole and brexpiprazole, but we can have some good suggestion about a more specific role. Now, please.
Sorry, I think I've made a lot of comments at this point. In practice, whilst aripiprazole does seem to have a bit of a safety net for THC, we are finding that it doesn't hold up because of the D2 receptor affinity of methamphetamine. So people who continue to use methamphetamine, even when on an aripiprazole LAI, continue to have as severe as psychotic episodes with ongoing methamphetamine use. Now, we don't see that as often with paliperidone, and the only long-acting injection we have that actually seems to cut that out is haloperidol or zuclopenthixol, and that seems to be related to the receptor affinity of those first-generation drugs. So, yeah, I know there's a lot in the literature about this, but I would see probably 3 or 4 people psychotic from drug use on aripiprazole a day in my emergency department, and so we tend to take them off and put them on drugs with higher D2 affinity because they're not stopping taking the methamphetamine.
No, I do agree. When the psychotic situation is very, very strong, of course, haloperidol is doing what haloperidol can do. Absolutely. Of course, probably you are you are seeing patients that are not responding, a very serious patient. I would say that at the beginning I would try to use a partial agonist, because in terms of for many factors that you know can be better, but when the situation is very strong, specifically with methamphetamine, the use of haloperidol can do what haloperidol can do, of course. Please, Diego.
Yeah. You're right. We have 2 gray areas, basically. One is people who continue to use substances. What to do? Increase the LAI, increase antipsychotics. You never know what is the best strategy, because, I mean, the substance is fueling psychosis anyway. And the other gray area that I'm sure you encountered many times is the opposite. So the patient who actually has not so florid psychotic symptoms, perhaps has no psychotic symptoms at all, but perhaps has a substance use disorder or cannabis use disorder. What to do? Prescribing an antipsychotic or not? Because it would be off-label, of course. But now it is happening quite often that patients actually ask for an antipsychotics when they have a cannabis use disorder, and you don't know if prescribing it because there are no psychotic symptoms, but the problem is using substances.
I would say that, for example, if we have a patient that after a period of intoxication and psychotic symptoms, after a period in the hospital, is starting to improve, but with negative symptoms, for example, that is the situation where partial agonists are working very well. But when we still have positive symptoms and the use is still something that the patient is doing, in that cases, we are going up with the blockage of the receptor, and in many cases, we have to use the haloperidol, of course. Now, last part of my presentation, because our aperitif is waiting for us, and how to manage dual depression is another point. We are in a completely different area. We are not speaking about psychosis, we are speaking about depression that in some way is anhedonia associated with the use of substances. So which could be the right antidepressant in dual depression, okay? Trying to look at which could be the ideal antidepressant in using substances and with depression. It should be something that should act on both conditions and address the core symptoms such as anhedonia, craving, sleep problems, cognitive dysfunction, while ensuring minimal emotional blunting, that is an important point with substance use, and with no addiction potential. What we know about classical antidepressants is that the data are not good enough. We know that antidepressant medication can have an effect on the major depression, but they do not have a specific effect in the comorbid substance use. So the data regarding SSRIs are not good at all in this kind of subject, and the reason is a pharmacodynamic reason, is this one. Because if I am utilizing the 5-HT2A receptor agonist blocking the SERT, the reuptake, of course, I am determining a specific effect on the GABA receptor as well, increasing the release of GABA. If I am increasing the release of GABA, of course, I'm improving with the patient in terms of anxiety, but I am determining on the dopaminergic neurons a situation of anhedonia. This is typical for SSRIs. How many patients that have been treated with SSRIs are saying, "Doctor, I'm doing okay, the situation has improved, but it's like I have a glass with the social reaction, with the social interpersonal situation." This is the SSRI-induced apathy syndrome. And of course, this is specifically connected with some antidepressants like paroxetine, venlafaxine, when venlafaxine is utilized at low dosages, acting as an SSRI, but also with citalopram. This is the frequency of patients reporting emotional blunting by drug type. So this probably those drugs that are able on their own to determine emotional blunting are not the right antidepressants that has to be used with substance use issues. So trying to hypothesize the right antidepressants, we could try to think other classes of antidepressants, like, for example, agomelatine, bupropion, trazodone, vortioxetine. But also we could act on different systems using low dose atypical antipsychotics, amisulpride, low dosages of aripiprazole, 5 milligrams, quetiapine, 1.5, but also cariprazine and quetiapine, but also mood stabilizers with the antidepressive properties like lamotrigine and other molecules, or in some cases brain stimulation techniques. So this could be some possible strategies. Here you can see with some level of evidence for anhedonia treatment. So we should try to look at possible antidepressants with these characteristics. And looking at some data, bupropion in dual depression has some literature. This is because bupropion is a noradrenaline and dopamine reuptake inhibitor with also acetylcholine receptor antagonism action, and we have some good data, and we have a lot of hope for this association. Dextromethorphan bupropion. We still don't have this combination available in Italy, but in the perspective could be something very, very relevant. We have some data regarding vortioxetine. This is because of the possibility to have also the efficacy mediated by the 5-HT7 interaction. And with vortioxetine, we have the absence of emotional blunting. We have to say that in many cases, the antidepressive effect is not that high, but it could be a possible option in with subject with substance use disorder. And we have some good data from coming from Spain and Italy as well. I have personally some good experience with acetyl L-carnitine, which is not an antidepressant. It's an endogenous compound that can increase the level of dopamine in the cortex, facilitating the cholinergic transmission and modulating the NMDA receptors. Acetyl L-carnitine can have some specific effects. Many years ago, we showed in this study some characteristics with the capacity to reduce anhedonia and craving in detoxified alcohol-dependent subjects. And then in my experience, I could report the possibility also to use esketamine in subject with treatment-resistant depression comorbid with substance use disorder, with some good results without the possibility to induce an addiction and tolerance, because using the product twice per week is something that is not able to determine a situation of tolerance or craving. Could be a possibility. And then, of course, the use of repetitive transcranial magnetic stimulation that is able to reach the dorsolateral prefrontal cortex, to have an antidepressive effect and some good effect on craving itself. In the literature, we have many data regarding TMS, so I do think that in the future is something that we utilize frequently in cases of dual depression. And then the use of trazodone. I don't know if in your country trazodone is available. It is good in Australia. In many countries it's not available. In Italy it's very common. Why trazodone could be a good idea? Because as vortioxetine does not have a specific interaction with the transporter of the serotonin, so it's not able to induce anhedonia and apathy, but can have an antidepressive effect, and as you know, has a good effect on the circadian rhythm to induce sleep, and with a very low abuse potential. So we have different data regarding in the literature regarding the use of trazodone, also in crack cocaine, but specifically with alcohol use disorder. So in my experience, is one of the antidepressants that are using in most of the cases of dual depression. Then, just to end my presentation, we have 4 more minutes, just to report some new trends, just to be optimistic at the end of the day. In this morning, I reported a lot of bad points regarding the increase of the psychiatric consequences, the MPS, vintage substances, very potentiated, and so on and so on and so forth. So what I would like to report is that probably in 2023, for the first time, we have a reduction regarding the use of substances in some specific class of ages. This is the trend regarding the US, regarding any illicit drug and marijuana use. You can see for the first time a reduction we are speaking about 8th, 10th, and 12th grade students, so 13, 14, 15 years of age. So this is a good data. Some authors criticize this data saying, okay, they are reducing the use of substances, but they are increasing the use of digital devices. This could be another point. Yes, of course. But I mean, looking from the perspective of substance use could be something good. And that's another good point. After many, many years of very dramatic numbers in terms of fentanyl deaths, we can have a fall of these numbers. So another important point. It was like an epidemic in the US and in other countries. So, I mean, it's another good data that we have to report. And then the last slide. Today I reported the use of party drugs, adolescents, young adults, but that of substances is also something that regards the elderly individuals. The Economist in the 2025 reported this term, aging disgracefully. This is an issue because, for example, in the UK, between 2018 and 2022, 38 people over the age of 50 died from ecstasy overdose. And in Italian addiction treatment services, 57% of those receiving assistance across various activities are over the age of 40. So, I mean, it's not just something connected to the Z generation, but it's something that regards the new boomers, and it's an issue that is covering all the ages. Also, it's a new trend, very interesting. This data is incredible. 2% of the elderly individuals report engages in active caregiving activities for their grandchildren. Today, I reported the horizontalization of the culture. Grandfather is not speaking with the grandchildren anymore. They are staying on their own. So society is changing. I don't know which is the direction, but it's dramatically changing to this respect. And with this data regarding the new boomers, this is the baby boomers that report higher illicit drug use. Look at this. Age 65 or older. So, I mean, it's something that to some respects can be very, could be incredible, but these are the data regarding the use specifically in the US. Okay. And with this, thank you very much for your attention. Now we have some practical information that we have to report regarding our tour. Otherwise, Marta is going to... We should have a slide. Please look at the slide because Marta otherwise... Ecco, that is very important. Che dobbiamo dire qua?
Okay, where you see the arrow, this is the meeting point for the aperitif if you go by yourself, because there are two entrances. So you have to go just in front of Molo Sant'Erasmo. If you go with Marta, you will arrive with her.
But no, please, I do suggest to do the tour with Marta. The tour is starting from here. We are going around Palermo, and then we are arriving where the arrow is. But if you don't want to go with Marta, but you are not going to say this to Marta, you can do whatever you want, and then reach the arrow point, okay?